Well, good morning, everyone. Well, it's good morning here in the UK at least. Hello, and a very warm welcome to this joint webinar run by the Royal College of Pathologists, the Egyptian Committee for Pathology Training, in collaboration with Shefa Al-Orman Hospital in Egypt. It's really wonderful to be joined by you all to discuss the topic today, which is microbiology challenges in oncology. So thank you very much for joining us. My name's Angela Davis. I'm a clinical academic and honorary consultant medical microbiologist at Swansea University Medical School in South Wales. Last week, I came to the end of my term as Vice President for Learning and International at the Royal College of Pathologists. So we're in our handover month, but in that capacity, I helped to organise today's meeting, which is how I come to have the privilege of welcoming you here today. I'm not going very far in the college, though, as I've just taken up a new role as the college's clinical director for publishing and engagement. So here is our agenda for today. We're going to have a brief introduction from each of the three organisations that are involved in today's meeting. Myself for the Royal College of Pathologists, Professor Mona El-Berawi on behalf of the Egyptian Committee for Pathology Training, and Professor Wassef from Shefa Al-Orman Hospital. So they will each introduce themselves to you formally shortly. And we'll then move on to our guest speakers, who are Professor Wassef, Professor Lewis White, Dr. Ed Bevan, and Dr. Majula Meda, who I'll introduce you to before each of their presentations. We're really very grateful to them all for giving their time to join us today and share their expertise. The topics that they are going to talk about are listed there, and they are based on those which were provided to us from Shefa Al-Orman Hospital as topics that you would particularly like to hear discussed and that you would find useful. After the speaker presentations, we'll have a panel discussion, and you're invited to enter all your questions for the panel into the Q&A box, which you can see on your screen. So you can write your questions there, and the panel will address those during the discussion session. You can also upvote questions in there by clicking on the thumbs up if you want to prioritise that question. So, a few words about the Royal College of Pathologists, which some of you may be familiar with, but others may not be. The college is a UK-based professional membership organisation with over 13,000 members, but nearly a quarter of those are based outside of the UK. We seem to be moving forward, I'm sorry. The college sets and maintains professional standards and promotes excellence in all aspects of pathology for patient benefit. And we have members and fellows who are medically qualified, veterinary qualified, and clinical scientists as well in 17 different pathology specialties. But today, of course, we're focusing on microbiology. Within the college, we have a small but very dedicated international team and an international strategy, which appears on the right there. And that document is on the internet, on our website, if you want to have a closer look at it. But I've listed here some of the key elements of the strategy. We provide support for exams and overseas examination candidates. We support audit and quality assurance practices globally and support pathologists throughout their careers, wherever they are in the world. We have a project portfolio which is related to our Pathology as Global strategy. We promote capacity building, professional development of our members and trainees. We have some volunteering opportunities, and we advocate for the college and its standards, its professional standards and educational standards around the world. So that gives you an idea of what the Royal College of Pathologists is about. But if you want to read more, do contact the international team at the college. You can find all the information about how to contact them and more details of our international strategy, as I said, on the Royal College of Pathologists website. I'm now going to stop sharing my screen because it's now my pleasure to invite my colleague, Professor Mona El-Bahraoui, to introduce herself and the work of the Egyptian Committee for Pathology Training. So thank you, Mona.
Angared, thank you very much for the introduction, and thank you very much for all the effort and time you have very kindly put it has been into developing this event for today, and same for Professor Wasif. It's been a pleasure to be working together to be here today presenting this very important topic to you, which is the challenges of microbiology challenges in an oncology hospital. I'm Professor Mona El-Bahraoui. I'm a professor of pathology at Imperial College London, and I'm privileged to be the current president of the Egyptian Committee for Pathology Training, one of the partner organizations that have been working to develop today's program. The Egyptian Committee for Pathology Training was established in October 2014 as a national professional body to support and enhance capacity in training and assessment and educational supervision in pathology in Egypt. And shortly after the establishment of the ECPT, we had the privilege of working with the Royal College of Pathologists under the auspices of the Supreme Council of Universities of Egypt to develop and sign a memorandum of understanding that was signed in Cairo in a very enjoyable event. And the aim of our work together is to encourage and facilitate postgraduate training in pathology in the light of the guidelines recommended by the Royal College of Pathologists, being a world-class organization that's leading training and development in pathology practice. At the ECPT, our activities are centered around education and assessment. We run, since we started, we've been running educational activities as in courses, conferences, seminars, and case discussions and practical microscopy sessions, as well as exam preparation courses. And our events range from one-day events to up to 2 weeks, depending on the subject we're addressing. The delegates that come to our events, including the examinations as well as the educational activities, are from different sectors of Egypt that have involvement in the field of medical education and healthcare delivery. So all Egyptian universities and academic institutions, the Ministry of Health, military hospitals, forensic authority, as well as charity hospitals. We also have delegates and exam candidates from overseas that come to the Egyptian activities and examination centers, colleagues from the Middle East, the Far East, as well as Africa. And we have attendees and candidates from all sorts of levels, junior doctors to the most senior levels, whether they are working in the NHS of the countries or academia. And our educational activities include events addressed to trainees and professionals, as well as train the trainer courses and trainee development days. And these photos are from previous events that we held in Cairo that were also supported and attended by senior members of the Royal College of Pathologists, as well as colleagues from Egypt and the United Kingdom. One important thing is also that we established the FRC Path Examination Center. The Part 1 Examination Center started since 2015, supporting candidates sitting the Part 1 exam in all disciplines of pathology before it became now completely an online experience. And we established the Part 2 examination in histopathology for the Fellowship of the Royal College of Pathologists in a Cairo Examination Center, which we have run in Cairo for at least 3 times now. One of the key events that we also ran in Cairo in collaboration with the Royal College of Pathologists is the International Pathology Summer School, and this was the flagship of this great initiative that is now currently running in different countries of the world as the International Pathology School. Our work with Shefa Al-Orman Hospital as an ECPT started many years ago, and we do again run educational activities there, as well as offer opportunities for actual in-house training for medical professionals, from undergraduate medical students up to more senior staff, both in pathology and in other disciplines, to let them know more about the services of the histopathology laboratory and the nature of the work and the workflow and regulations, because obviously pathology serves or works in interaction with different disciplines in medicine. So it's important that different colleagues in different disciplines have a good idea about what we do in the pathology laboratories. And this is a photo from one of the educational practical workshops that we held there. And our work also extended to get the support and also support interactively the work of the Royal College of Pathologists since many years ago, 2019, I believe, we started running an event at Shefa Al-Orman Hospital in celebration of International Pathology Day. And this has been one of the key things in our calendar at Shefa Al-Orman Hospital, just to celebrate International Pathology Day every year. And this has this collaboration has now developed into what we have today, today's event, and it's a pleasure to see this collaboration between the 3 bodies progressing and expanding. And thank you all for being here today. It's a pleasure to be here with you. Thank you.
Thank you very much, Mona. Shall we also have an introduction from Professor Wassef, please, if you're there? Professor Wassef, you are muted at the moment and we can't hear yet. Thanks.
Good morning, everybody. Thank you so much for arranging this very important event. We are happy to be with you, presenting our processes, challenges in our micro lab in Shefa Al-Orman. I'm Professor Mona Wassef. I'm Professor of Clinical and Chemical Pathology, Cairo Faculty of Medicine, Cairo University, Kasr Al-Aini. Here in Shefa Al-Orman, I am head of Clinical Micro Department and head of Infection Control Department as well. I worked here with Shefa Al-Orman team since 2016, I think. From the early beginning, now we have a fully automated, highly equipped lab with a very efficient and highly trained team. And I'm going to present my team and my processes and my equipment in my presentation, if you allow me, if you please. My presentation will be about the role of clinical micro lab in SOH, challenges and processes. I will present the role of clinical microlab in diagnosis of different types of infections, such as bloodstream infection, anaerobic infections, candida infections. And then I will present a sample from our cumulative antibiogram and to see the role of antimicrobial resistance in our cancer patients, as well as the role of colonization of these patients with superbugs. And I will present the challenges all through my presentation. Next. Cancer patients have increased susceptibility to a variety of both common and atypical infections due to many risk factors. Already immunocompromised patients' chemotherapy regimens lead to neutropenia, deficits in cellular and humoral immunity, and disruption of mucosal barriers that predisposing them to severe disease presentations with high morbidity and mortality rates. Next. This slide shows us the very famous and very important and very dangerous escape superbugs. Escape is the initial of E for Enterococcus faecalis, S for Staphylococcus aureus, K for Klebsiella pneumoniae, A for Acinetobacter baumannii, P for Pseudomonas aeruginosa, E for Enterobacter or Enterobacterial, gram-negative Enterobacterials. In the second column, we can see different types of clinical infections that may be caused by these important and dangerous pathogens in different types of cancer patients, as we see. Next. This is our micro lab. We can see here the two fully automated blood culture system, the Bactic and Bact Alert, and the anaerobic culture system. Next. Here it's a fully automated IDAST identification and the antimicrobial susceptibility machine for any bacteria, which is the Vitek 2. Next. This is the BioFire, which is a multiplex PCR, fully automated for syndromic testing, as we are going to see. Next. This is the Gene Expert, also a PCR, but different from the BioFire we are going to mention. Next. And lastly, the Vitek MS or the MultiTOF. Next. The Infectious Disease Society, the Infectious Disease Society of America recommends the addition of rapid diagnostic testing to an effective antimicrobial stewardship program. So SOH-RDT solution was to have MultiTOF for rapid, accurate identification at the species, genus, or group level of any bacteria, whether typical or atypical, fastidious, difficult to grow, aerobic and anaerobic, as well as fungi, molds, and yeast, just in few minutes, about 10 minutes. Then the BioFire film array for syndromic testing to identify or to detect more than 30 targets only within 1 hour, just directly from the specimen, without cultivation in advance, without being cultivated, just work direct from the sample. These 30 targets are different gram-positive, gram-negative, as well as some yeast, as well as some antimicrobial resistant genes, as we are going to see. And then the Gene Expert, it's a monoplex PCR for one pathogen, but also for many targets. I mean, we can also diagnose, for example, Mycobacterium tuberculosis directly from the specimen without cultivation, in addition to its to detection of its rifampicin resistant gene, also closely automated, fully automated closed system in 1 hour process. Next. We are going to begin with the bloodstream infections. We can see here the difference between the rate of positive cultures in bloodstream infections between pediatric and adults. The rate in adults is 31 positive cultures in bloodstream infection, 31%, and it is 13 in pediatric. Next. We can see here that in both adults and pediatrics, gram-negative are more important than gram-positive pathogens. Next. Among the gram-positive, we can see here that Staphylococcus aureus is the most predominant or the most common gram-positive pathogens in both adults and pediatrics. Next. As regards gram-negative, E. coli is most predominant in among adult gram-negative pathogens, while Klebsiella pneumoniae is the most common in pediatric. Next. As regards candidemia, I mean candida isolated from cases of bloodstream infections, we can see here that Candida tropicalis is the most common from adult cases, while Candida parapsilosis is most common in pediatrics. Next. Then we come to anaerobic infections. Next. We all know that anaerobic infections is increasing in both cancer and in non-cancer patients. Some examples of anaerobic pathogens that we can detect and we could cultivate in our lab. For example, some of the gram-negative and gram-positive Bacteroides theta atomicron, Bacteroides fragilis, Veillonella dispar, Clostridium barati, that were isolated from different clinical samples such as mandibular abscess, bloodstream infection, abdominal correction, bilirubin, from different cancer patients with cancer breast, acute myeloid leukemia, cancer kidney, gallbladder, stomach, and rectum. Next. Vitek MS is very helpful for us to identify these challenging pathogens just in few minutes, as I mentioned, but after cultivation in the anaerobic system, as I mentioned in the previous slide. Next. Also, Vitek 2 is helpful in such situation. Next. Next. I think Candida infection was mentioned before. Next. To come to the very important syndromic testing. Next. This is what I mean by syndromic testing, to have a panel. This is the first panel, which is a blood panel. We can see here, this is our first case of bloodstream infection, which was a polymicrobial sepsis caused by Staphylococcus, Klebsiella pneumoniae, as well as Candida albicans, as were identified by the BioFire. This is the first panel in the BioFire, which is the blood panel. As we can see here, we have many gram-positive bacteria, many gram-negative, many yeast, as well as many antimicrobial resistant genes. Here also we can see in this case, we have 3 antimicrobial resistant genes, CTXM, NDM, OXA48-like, which means CTXM that the pathogen is resistant to extended spectrum cephalosporin, NDM and OXA48-like, it means that the pathogen is resistant to carbapenems. Next. A second case of bloodstream infection caused by Candida glabrata. Next. This is the second panel, which is the GIT panel, to identify different causes of bacterial diarrhea, viral diarrhea, parasitic diarrhea. This case, as we can see here, was caused by enteropathogenic and enterotoxogenic E. coli. Next. Another case, in addition to the enteropathogenic and pathogenic and toxogenic E. coli, enteroinvasive and sapovirus. Next. The third panel, which is meningitis encephalitis panel, and here is a case of herpetic meningitis caused by herpes simplex virus 1. Next. The fourth panel is the pneumonia panel plus, which is a little bit different from the previous panels, because here we have semi-quantitative count. As we can see, we have 2 gram-negative, 2 important gram-negative, Acinetobacter baumannii and Klebsiella pneumoniae, with 10 to the power 7 count, which is 10 to the power 7, which means that it is most probably is clinically significant count, as well as the resistant genes, as I mentioned before, CTXM, NDM, OXA48, and no atypical bacteria. what we mean by atypical bacteria, Legionella, Chlamydia, Mycoplasma. No atypical bacteria was detected and no viruses in this case. Next. While in this case, another case of pneumonia, Streptococcus pneumoniae, caused by Streptococcus pneumoniae, and parainfluenza virus. So either it started as a viral pneumonia and then become complicated by bacterial infections, or the reverse. And Streptococcus pneumoniae also with clinical significant count, which is more than 10 to power 7. Next. The last panel is the respiratory panel 2.1, which can detect most of the viral causes of atypical pneumonia, which are the causes of viral pneumonia. Here we can see a case of respiratory syncytial virus in addition to human rhinoenterovirus. Next. And here a case of the very famous COVID, SARS-CoV-2, in addition to para-influenza virus. And this picture was very common to have another viruses in addition to SARS-CoV-2 or COVID virus. Next. Now we come to our cumulative antibiogram. It is a sample from pediatric antibiogram. It is a half-annual antibiogram from January to July. This is very also we have to separate sure gram-negative from gram-positive. So this is the cumulative antibiogram of gram-negative. And here we have very important finding to have 40% of E. coli to be MDR and 69% of Klebsiella pneumoniae to be MDR, and 22 of Pseudomonas and 42 of Acinetobacter, with 100% susceptibility to tigecycline, amikacin, and the rest of the important antibiotics we are using in our empiric policy in the hospital. Next. This is the antibiogram of gram-positive. Here also another important finding to have 93% of our isolates of Staph aureus to be MRSA or methicillin-resistant Staph aureus, with 100% susceptibility to tigecycline, vancomycin, linezolid, teicoplanin, but this is, of course, very serious finding to have this high rate of MRSA. Next. Next. This is our results of pre-admission screening for adult carriage of nasal carriage of methicillin resistance, and as well as pediatric. We can see here the rate of adult carriage of nasal MRSA to be 12% and 10% in pediatric. Also, we make pre-admission rectal screening for pediatric patients for different superbugs. Here we can see that 39 of we have 39 carriage rate with ESBL, extended spectrum beta-lactamase, and 20% rate carriage of ESBL in addition to carbapenem resistant enterobacterials. This is in pediatric. And pre-admission screening for preoperative colonic surgery, the rate is 25% for ESBL and carbapenem resistant enterobacterials carriage for rectal superbugs, and 39% ESBL carriage. Next. Next. This is very important to know the carbapenemase genes. We can see here the most important gene in carbapenemase produced by our gram-negative pathogens in the hospital in Egypt as a whole, to be the NDM class B, to be 35%, followed by OXA48 to be 14%, and we can see here that KPC is almost very rare. Next. Next. This is our latest publication about the rate of superbug carriage in our children in the pediatric hospital, and was published in the International Society of Pediatric Oncology. And we can see here the rate of colonization to be 29% of rectal carriage of ESBL and CRE producing organisms. Next. All these activities are under the umbrella of antimicrobial stewardship. Next. We have a complete full team of antimicrobial stewardship, as we are going to see. In our team, represented the medical oncologist, pediatric and adult, clinical pharmacist, clinical microbiologist, infection control practitioner, surgeons, intensivist, and the head of our central lab. Next. At the end, I'm very grateful to my beloved team in the clinical micro lab, Nurhan, Hagar, Layla, Alia, and Adli are not present in the photo, and our director of the reference lab, Dr. Faye, and thank you so much.
Thank you very much, Professor Wasser, for that really interesting and clear summary. It's really interesting for us all to hear about practice in your hospital in Egypt, in Shefa, Al-Orman, and to hear about the profiles of the pathogens that you encounter. We are mainly going to plan to have most of the questions during the Q&A session, but we do have one question already here from a member of the audience, so I'll pose this to you now. The question is, have you done any environmental screening? Looking at MRSA and CPA ESBL screens, much lower prevalence than the positive blood culture rate.
Usually we have environmental screening during outbreaks. When we have any trend in number of pathogens, usually we do environmental samples from the departments in which we notice the increase in such pathogens, and usually it is gram-negative, not the MRSA staff. Sometimes once we had an outbreak with Burkhardia, once with Acinetobacter, but not, this is, unfortunately, this is the rate of resistance in all Egypt.
Thank you. And if people want to ask more questions, then please keep entering them in the Q&A at any time, and we'll address them all during the panel session after all the talks. So thank you very much. And we now move on to our next speaker, who is Professor Lewis White. Professor White is a clinical scientist by background, and he's head of the Public Health Wales Mycology Reference Laboratory in Cardiff in Wales, in the UK. He's worked there for many years, specialising in diagnostic testing for fungal infections. And this was one of the topics that we were specifically asked to cover because people wanted to know about it. So I'm sure people are looking forward to your talk, Lewis. Thank you very much for joining us.
Thank you, Angharad. Hopefully I don't disappoint. So the first technical hurdle to overcome is, can I share my screen? Right. Hopefully you can see my slides. Angharad, can you confirm? Not hearing anything?
Yes, we can see them.
Thank you. Brilliant. The next thing is, do they move? Let's try. So I'm going to talk to you about diagnosis of fungal infections. It's something that I've been involved with for the past sort of 25 years, or approaching the past 25 years. I'm particularly trying to sort of embrace sort of novel technologies, but also sort of implementing diagnostic strategies in our high-risk hosts. So hopefully the slide has moved on to the next one. If I don't hear anything, I will assume it has.
Fine. It's all looking
Wonderful. Wonderful. So the one thing to take into account when it comes to fungi is exposure to fungi on a daily basis is inevitable. We have fungi such as Candida on our commensals on our mucosal membranes. Every day, from an environmental perspective, we inhale several hundred, maybe even several thousand sort of fungal spores, primarily Aspergillus fumigatus. Lots of spores if you sort of work in agriculture or you work in construction. But not really historically, but generally, invasive fungal disease is sort of thought to be limited to those with underlying conditions or underlying sort of clinical interventions, and generally is sort of your immunosuppressed patient, your acute leukemia, particularly your acute myeloid leukemia, your allogeneic stem cell transplantation patient, your solid organ transplantation patient, those with sort of underlying respiratory illness, or those going through major surgery where you see disruption to anatomical membranes and then giving the chance for Candida to become invasive. And the question is do we need to worry about other populations? We are seeing increased levels of immunosuppression, and that includes our oncology and our hematology patients. We're seeing more widespread use of prolonged corticosteroids. We're seeing more use of monoclonal antibody therapy, particularly in our populations, such as those with myeloma or lymphoma. They were once considered to be low, maybe moderate risk of invasive fungal disease, with the exception of PCP, which is probably a higher risk. But now that risk is increasing through the monoclonals and the use of steroids. We're also seeing change in populations. Obviously, we've just come through a COVID pandemic, and we saw high rates of fungal disease in COVID, and we also see high rates of fungal disease in patients with influenza. But we're seeing change in populations in oncology, as I said, increased levels of immunosuppression. But we're also seeing differences in the way that sort of allogeneic stem cell transplantations are given to our patients. It used to be a fully myeloablative approach. Now we have a sort of a reduced intensity of chemotherapy, non-myeloablative approach. And that potentially changes when patients are at risk of fungal disease, and also potentially how our assays perform. And so in our patients with RIC-MUD allogeneic stem cell transplantation patients, they're not neutropenic as our patients once were post-allogeneic stem cell transplantation. And then we do wonder whether tests like the galactaman and ELISA assay on serum actually really, will work as well in that population. And so we're seeing new risk factors, we're seeing changing populations, and there's a heavy reliance on conventional mycology, and it's not clear as to really are we getting a true idea of the incidence of fungal disease. And although biomarkers are available, there can be limited access to biomarkers, and there can be poor utility in terms of turnaround time, so they don't really impact on patient management. When it comes to expenditure on antifungals, the UK spends on average around 100 to 150 million pounds per annum, and in the US we're talking billions of dollars are spent every year on treating fungal disease. But antifungal expenditure is completely out of proportion with the scale of the problem. If you look in our hematology cohort, incidence would be anywhere between sort of 1 to 10%, depending on whether you're using something like antifungal, anti-mold, active prophylaxis. Obviously at that lower end if you're using mold active prophylaxis. In Cardiff, we don't use mold active prophylaxis in our high-risk patients. We rely on biomarkers. And our incidence is somewhere around sort of the 9% mark. And so what are the reasons for us using so much antifungal therapy in our patients when disease is actually sort of very limited, or at least based on the conventional diagnostics in mycology is limited? Well, infection is associated with significant morbidity, but also mortality, and delays in treatment are associated with poorer outcome. So for instance, in your patient who has aspergillosis, if they're treated appropriately within the first week, mortality is going to be around the 30 to 40% mark. If you delay appropriate therapy by that sort of another 7 days, that mortality is going to double up to around the 70% mark. Signs and symptoms of systemic infection are typically non-specific, and even when we do get the typical signs, they can be transient in presentation. And as I mentioned, conventional diagnostic techniques are suboptimal, and there's also problems with access to novel techniques. So subsequently, there's this reliance on empirical antifungal therapy that was introduced back in the 1970s when we didn't really have diagnostics available to us. So what are our diagnostic options? Well, any microbiology lab is going to be able to offer you culture. Okay, it's sort of the backbone of microbiology testing. The benefits when it comes to mycology is it can be applied to a wider range of specimen types. Okay, we can put it onto solid media or we can put it into liquid media and try to grow fungi. It has a broad detection range. One exception is pneumocystis, which we can culture using axenic culture, which is a form of tissue culture, but this really plays no role in a routine diagnostic laboratory. And there are other fungi such as Malassezia that are difficult to actually culture within the laboratory, but most fungi will grow. Once we have an isolate, we can perform adjunctive testing. It obviously performs part of the identification of the fungi. And we can also have the fungi then available for susceptibility testing. And then we have breakpoints, whether they be CLSI or UCAS broth microdilution methods. We have breakpoints, but they are limited to sort of the main causes of fungal disease. Candida albicans and the other sort of common Candida species, Aspergillus fumigatus, and generally outside of those, we have limited breakpoints for interpreting what an MIC actually means. Limitations with culture primarily are sort of directed at sensitivity. Candida is about 50%, blood culture is about 50% sensitive for the diagnosis of invasive candidal disease, and it's a similar figure for the diagnosis of invasive aspergillosis when you perform culture on a respiratory tract or primarily a bronchoalveolar lavage fluid. And the other limitation is potentially turnaround time. While we do occasionally culture fungi within sort of the first 24 to 48 hours, occasionally prolonged culture is needed, taking up to 7 to 10 days to actually recover an organism, and that limits the clinical utility of the test. One thing we have to take into account is that certainly in the UK, most primary culture is performed outside of mycology. Okay, and basically the bacteriology labs that are receiving those specimens and then basically are inoculating our SAB plates follow UK standard microbiology protocols. And those protocols are optimal for the recovery of bacteria. Okay, if you look at SMIB 57, which is for the processing of respiratory tract specimens, including BAL fluid, it basically, you would dilute down that specimen, you would then add something like mucolysis to make it less viscous, and then you would plate 1 microliter. That's optimal for the recovery of bacteria, but it's really suboptimal for the recovery of fungi. And indeed, we've modified that protocol to sort of inoculate things around 200 microliters of specimen in our CF population. But again, that's probably still not optimal, and we need to really increase that volume when we're looking at patients that are high risk of fungal disease. With blood cultures, SMIB 37, it recommends 20 to 30 mils of adult blood per set. However, the ESCMID guidelines say you actually have to inoculate 60 mils of blood across 3 sets to get the optimal recovery of Candida in blood cultures. So again, not optimal protocols. So we can use larger volumes to improve the recovery of fungi. We can have prolonged incubation times, 7 to 10 days, maybe even longer. And we can have incubation at different temperatures, sort of 30 degrees, 37 degrees, and 42 degrees can be used. The problems are, in most routine bacteriology laboratories, when you try to implement these sort of differences or these different protocols to improve recovery, it's met with logistical issues. It falls sort of the situation where that prolonged incubation time means they have to keep plates longer than that is convenient for them, or actually using more incubators at different temperatures is just simply not possible. Another approach is actually just to say, okay, well, apply these optimal processes for samples that come from patients at risk of fungal disease. But quite often in the microbiology laboratory, you don't get that information on the form, so it's not possible to identify such patients. And I think there's a bigger issue that there's probably limited understanding of the issues of mycology and the significance of mycology outside of the high-risk hosts. And so subsequently, most bacteriology labs have confidence in the SMIs that they're using. And there's ignorance of actually the incidence and the diagnosis of fungal disease. And this propagates a vicious circle that needs to be broken as we go forward. The other stalwart of mycology in particular is microscopy, where we take a specimen, particularly a fluid, and we look down the microscope to see if we can see fungal elements. Again, can be applied to a wide range of specimen types and actually forms part of the culture ID, where we look for sort of fungal elements and branching angles and whether there's cross walls down the microscope. Unlike culture, it does provide us with a rapid identification and arguably should be available within sort of 4 hours of receiving the specimen. It does have a broad detection range, but that broad detection range in terms of differentiation is highly dependent on the sort of the experience of your operative. Okay, and if you don't have a person who's sort of very, very good at looking down the microscope, this process can become very, very difficult to differentiate between fungi. Sensitivity is also limited, probably below that of culture. And of course, we don't then have an isolate for adjunctive testing if you only perform microscopy. Nevertheless, they form the backbone of our sort of diagnosis, our reference standard for the diagnosis of invasive fungal disease. This would be a proven fungal infection. And this reflects culture of fungi from a deep or sterile site, or histological or microscopic evidence of fungal elements in a tissue specimen or a sterile specimen. But we have to bear in mind that this is highly specific, but not necessarily highly sensitive. So when you find something, this patient has disease, proven disease. When it's negative, you cannot use it to exclude infection. And this is all derived from the EORTC MSG definitions that we use to define fungal disease in the high-risk host. Now, these definitions were put forward for clinical trials. However, they are applied routinely in clinical practice. And there's no question about a proven diagnosis. That's fine. But that probably represents, I would say, probably less than 5% of what we see in clinical practice. And so more often than not, we're dealing with a non-proven classification, where there's a requirement for host factors, as I've described previously, and there's an emphasis on clinical and radiological presentation. But these definitions are put forward for the classification of disease, not infection. And we also need to bear in mind that the clinical, but more so the radiological presentation, is temporal. It changes over time. It can be influenced by the host and whether they have sort of an underlying condition that can be deemed classical or not, and also the impact of clinical practices, which I've already described. And also radiological presentation is subjective and can really sort of influence what we do in clinical practice. So I've mentioned clinical populations are changing, host factors are changing. Subsequently, the clinical and radiological presentation may be not typical and in terms of the presentation, but also the timing of the signs in our patient population. And it's also important to take into account that these definitions are designed to be highly specific, but not necessarily highly sensitive. So these are the clinical signs for invasive fungal disease as presented in the EORTC MSG ERC definitions. I'm not going to go through them. The publication is widely available, it's open access, and it's available from Clinical Infectious Diseases. But what you can see is that they are potentially subjective and they will be temporal. For instance, in our typical hematology patient, it used to be post a myeloablative stem cell transplantation. You'd expect to see a halo or a nodule within the first sort of 3 weeks post stem cell transplantation. And then 3 months later, you would potentially sort of start to see the air crescent or the cavity sign. Nowadays, that might not be the case. But it's also important to bear in mind that these are typical for an invasive fungal disease, but not specific for an invasive fungal disease. And just to give you an example here, that nodules both appear in the diagnosis of pneumocystosis and the diagnosis of invasive aspergillosis. And these manifestations are consistent with disease. But what about if you want to preempt disease? What if you want to try to make a diagnosis during the infective process where radiology may be not typical or not sort of or less specific for the manifestation you're trying to diagnose? Now, this is just an indication of how radiology can sort of influence your judgment during day-to-day practice of patients at risk of invasive fungal disease. So the top one is purely made up, but it's certainly something that we see within the clinic. So these are patients with host factors. So in this situation, an acute myeloid leukemia patient or patient with allogeneic stem cell transplantation. Both present with bilateral consolidation on chest CT. One has a serum galactomannan, sort of moderately positive in serum, and aspergillus is recovered from sputum. The other, again with bilateral consolidation, has a galactomannan from BAL, again moderately positive, and aspergillus is also positive in serum intermittently but on several occasions. According to the EORTC MSG definitions, they would not have invasive aspergillosis. Clinically, I would treat both of those patients. And it might be that when in this situation, based on the radiology, we're dealing with probable invasive fungal infection, rather than probable invasive fungal disease. The bottom bullet here actually is a true report from a patient that presented with atypical pneumonia and at the time of presentation was then diagnosed with HIV, so high risk for pneumocystis. So the chest CT report said, allowing for technical quality, there was lower lobe predominant ground glass opacification with superimposed faint nodular infiltrates. Okay. And the report said features are not consistent with pneumocystis in this distribution, nor fungal or other opportunistic organisms. However, what's seen there on chest CT would actually meet the requirements as highlighted in the ORT-CMSG definitions. We performed a PCR on a throat swab, which in our hands, when positive, is highly specific, and it came back with a relatively early CT value, which was 99% specific for the diagnosis of pneumocystis pneumonia. Serum beta-glucan was greater than 500 picograms. So based on these combination of mycological evidence, there's almost 100% specificity for this patient having pneumocystis pneumonia. They were successfully treated with prednisolone and IV Septrin following the guideline recommendations. So undoubtedly, this patient had pneumocystis pneumonia. So where are we in terms of non-culture diagnostics? I'm going to sort of go through molecular, I'm going to go through serology, and I excuse my broad use of the term serology here when I'm including antigen assays in that term. I'm not really going to focus on antibody assays because they are useful for the diagnosis more of chronic and allergic disease. Whether they have a role in sort of acute invasive fungal disease, it's difficult to say, but certainly probably not in the immunocompromised host such as the oncology, hematology patient. There also may be a situation that in things like invasive mold disease, there's potential delay in patients who can develop antibodies, and probably in a situation where it takes 2 to 3 weeks for antibodies to develop in a patient with acute invasive fungal disease. And then on top of that, in acute sort of yeast infection, we can get sort of issues in terms of the accuracy of antibody tests because of the presence of commensals in terms of candida in most patients. So to start with, I'm going to focus on the Galactomannan ELISA, so the Aspergillus ELISA, which is basically the stalwart for the diagnosis, for non-culture diagnosis of invasive aspergillosis. It doesn't provide us with species level identification, and indeed there has been differences in its performance dependent on the species of Aspergillus. And obviously it can't tell us whether there's any sort of resistance detection resistance associated with the infection. However, in a situation where you have Galactomannan index values that sort of are staying high or increasing despite the presence of antifungal therapy, you may want to consider a refractory or resistant disease. Now, it was a commercial assay that was originally released back in the 1990s after there was a latex agglutination test that wasn't particularly sensitive nor specific. And so that latex agglutination assay was replaced by this commercial Galactomannan ELISA that uses the monoclonal antibody EBA2 to detect the galactofurin side chain. Now, it's FDA and CE marked for the detection of galactomannan in serum and BAL, although it can also be used in plasma and CSF, although the kit isn't sort of licensed for those specimens. In serum, you get a sensitivity and specificity around the 80% mark, so it's not a perfect test. And to give you an idea of that, if you have an incidence of around 10%, the probability of invasive aspergillosis associated with a positive result above a galactomannan index of 0.5, then the probability of IA with a positive result would be 30%, and a negative result would be around 3%. And we also see variable performance, despite this being a standardized kit, and really this kit hasn't changed in terms of its process for pretty much, and since it was launched back in the 1990s. We do see false positives historically with antibacterial agents that come from sort of a penicillin-based source. You can also see false positivity with blood products, including plasmolytes, and you can also see potential false positivity with things like IVIG. False positivity can also occur with food sources such as pasta and tea. And we also see cross-reactivity with Penicillium, Fusarium, Bacillomyces, and Histoplasma. So it's not solely specific for the diagnosis of invasive aspergillosis. The optimal positivity threshold will potentially vary. Arguably use a 0.5 threshold to generate the highest sensitivity and greater than sort of 1.5 to generate the highest specificity. But the positivity threshold has varied considerably across the ORT-CMSG classifications. And there are now other versions of the kits becoming available. And obviously these have different kinetics and they have different thresholds. So we really need to generate clinical validation of these new kits to determine what is the optimal performance parameters for these new versions. Beta-glucan is another fungal antigen. It's a pan-fungal biomarker. It's put forward as a pan-fungal biomarker. The exception being Cryptococcus and Mucorales. It is present in the cell wall of Cryptococcus, but only at small amounts. And potentially, if your patient has cryptococcemia, you might get a positive beta-glucan in serum. Mucorales, beta-glucan is completely absent from the cell wall. The actual process exploits the clotting cascade of the horseshoe crab, which is the horseshoe crab's immune response to invasion with both bacteria and fungi, is highlighted in the algorithm, which I won't go through. There are various commercial assays available, and they have different cutoffs and they have different kinetics, which sort of makes having a single sort of approach to understanding the diagnosis or the performance of the test difficult. Sensitivity and specificity when testing serum is similar for basically similar to the galactoman analyzer for invasive aspergillosis at around 80% sensitive and 80% specific. And when we break it down for the performance for invasive candidiasis and invasive aspergillosis, again, it's about a similar mark. And indeed, for fusariosis and scedosporiosis, primarily in the hematology patient, again, that sensitivity is around the 80% mark. What we shouldn't do is basically use the beta-glucan test on respiratory tract specimens. That is because the presence of commensals and also colonizing fungi will drive down specificity. And in the situation where you actually do test respiratory tract specimens, specificity will be below 50%. One place where beta-glucan is a useful test is for the diagnosis of pneumocystis pneumonia. And you can actually see that you get a really high sensitivity of between 90 and 95% and a subsequent really high negative predictive value and a really low negative likelihood ratio. So when beta-glucan is negative in serum of your patients, the probability of pneumocystis is very, very low. While specificity is moderate, around 80 to 85%, it's then not reflected in sort of the positive predictive value or the positive likelihood ratio. So beta-glucan for confirming pneumocystis is not ideal, and you really need to combine it with another sort of test, ideally PCP, PCR, and I'll touch on that in my closing slides. And what about sort of beta-glucan for the diagnosis of pneumocystis in the non-HIV patients? And in Europe now, 80% of our cases of pneumocystis occur in the HIV negative patient. Well, actually, that sensitivity will actually drop to around 85%. So subsequently, again, you probably need to combine beta-glucan with a molecular test for pneumocystis. We're also in the situation where we're seeing lateral flow devices for the diagnosis of invasive fungal disease revolutionize the diagnosis of cryptococcosis, where we've probably got the best test in mycology. We've all become familiar with the use of lateral flow assays for cryptococcosis, really high sensitivity, really high specificity in both serum and CSF for the diagnosis of cryptococcosis. So these cheap, easy to perform tests are now also available for the diagnosis of invasive aspergillosis. One such assay here is the OLM assay, which arguably performs better when testing BAL fluid, likely associated with a higher burden you would expect to see in that specimen type, but sort of a decent specificity and sort of moderate sensitivity when testing blood. The IMI lateral flow assay, which is also available for Aspergillus, will give you a higher sensitivity than the OLM assay when testing blood. So it's a potential alternative. We're also in a situation now where there are lateral flow assays for the diagnosis of invasive aspergillosis when testing urine samples from Pearl Diagnostics. An initial study here looking at proven probable aspergillosis in the hematology setting, or primarily the hematology setting in Fred Hutch, has actually showed good sensitivity and an excellent specificity. So again, lateral flow applicable to an easily obtainable specimen. So what about molecular tests? Well, yep, they're available, now commercially available. They're rapid, broad detection range. They can be truly pan-fungal if designed to be so. They can be highly sensitive, picking down to 3 copies of DNA per reaction. They can be highly specific. So if you design them to pick up a strain of a fungal species, they can do so. So subsequently, they can actually pick up mutations that are associated with antifungal resistance. And they can be multiplexed to pick up multiple different species, multiple different genera, or also to pick up a particular species and mutations associated with Aspergillus, or sorry, associated with resistant. And this is particularly true for azole resistance in Aspergillus. Limitations are the requirement for specialist equipment and specialist staff, and potentially limited standardization. However, for aspergillosis, this is no longer true. We have extensive standardization, and the processes that we actually employ are in line with molecular tests for the detection of viral pathogens. So if you have access to a molecular suite or molecular diagnostic laboratory that's performing assays for the detection of viral pathogens, there's arguably no reason why you can't be performing molecular tests, certainly for the recovery of aspergillus and probably for the recovery of candida. They are potentially expensive, but not more expensive than things like beta-glucan testing. And while we do generate false positives, the rates of false positives are no greater than what we would actually see for the sort of serological or the antigen tests, although they are from a different source. When you look at the performance of PCR and when tested in blood, so in this situation is a high frequency screening test where we want a high sensitivity and a high negative predictive value, you can see that through meta-analytical evaluation, PCR on blood provides us with a higher sensitivity than both galactomannan and beta-glucan, numerically at least. And the negative likelihood ratio is getting towards the point that a negative PCR in blood, when consistently performed and consistently negative in your haematology patient, is sufficient to exclude aspergillosis. What about on BAL? And in this situation, you've obtained the BAL through bronchoscopy because your patient has signs and symptoms that may well be typical of invasive aspergillosis. So it's an infrequent test and you're reliant on a high specificity and a high positive predictive value. Here, you can see numerically at least, the specificity of PCR through meta-analytical review is greater than that of the galactomannan analyzer, and the positive likelihood ratio is sufficient to confirm infection when positive. We can also use Candida PCR to aid in our diagnosis of invasive candidiasis to try and pick up that missing 50%. Meta-analysis actually shows a really high sensitivity and specificity when testing blood. However, this data is over 10 years old and it really needs to be reviewed. In relation to combination testing, we really don't know what the best sort of combination tests are, whether we combine in PCR with certain antibodies or antigen tests. We still really don't know that. However, the ASTOP study, which is a UK trial, hopefully will give us that answer. In relation to picking up resistance, very difficult, because of sort of the number of mutations we see and the mechanisms we see associated with azole resistance in Candida species is huge, and probably sort of obviates the use of a PCR test for the diagnosis of resistance direct from clinical specimens. However, maybe for sort of kind of Candida resistance, this might be possible, but probably be looking at using things like next generation sequencing. One test which is sort of gained publicity over the last few years is the T2 Candida meta-analysis. Again, shows really good sensitivity and specificity, but performance does vary considerably when you have invasive candidal disease in the absence of candidemia, where the sensitivity does drop away. Another test which we actually have available in Cardiff is Mucorales PCR, and I think this really has some utility given the current lack of a biomarker and antigen test for the diagnosis of mucormycosis, although there are lateral flow assays in development for the detection of fucomannan and in the Mucorales organism. There is validation in France, multi-trial center in France, the MODI-MUCO trial, which gave us good sensitivity and excellent specificity when testing blood for the diagnosis of mucormycosis, which actually makes sense in a way because actually Mucorales species need iron to metabolize, and the biggest source of iron in the human body is in the bloodstream. So there is a rapid disease, they're highly angioinvasive, and because of the lack of crosswalls in the Mucorales hyphae, there's a high availability of the DNA in the bloodstream of your patient with mucormycosis. PCP PCR is also a very, very useful test. High sensitivity, high negative predictive value, and a really low negative likelihood ratio. So when negative, you can really exclude the presence of PCP in your patient. Specificity is high, is excellent, and subsequently the positive predictive value and the positive likelihood ratio are again sufficient to confirm infection when positive. And bear in mind that nowadays we are using quantitative methods. So subsequently, the higher the burden, the higher the probability of infection. What about the non-HIV patient? Well, PCP PCR doesn't seem to vary whether based on HIV diagnosis or not. Upper or lower respiratory tract specimens, well, the presence of a PCP positive in the upper respiratory tract is now highly indicative, highly specific for diagnosis of pneumocystis, and reflects a high burden of PCP in the lower respiratory tract. I'm just going to finish now on combination testing, which for aspergillosis can be applied in two different ways, really, which is a screening strategy. So this is your high-risk hematology patient who's, I never say that they're actually well, but doesn't really have signs of infection. And you're doing sort of once weekly or twice weekly screening through their admission. If they test consistently negative, primarily galactomannan combined with Aspergillus PCR, you can withhold antifungal therapy. If they screen positive, you may want to consider antifungal therapy, but more so, you're going to do a diagnostic workup with chest CT and obtain a BAL fluid. Alternatively, you can go down the route of a diagnostic-driven strategy, where a clinical trigger, maybe refractory fever, maybe non-specific signs on chest X-ray, then would basically promote the use of the antigen and molecular tests in blood, at which point you may want to consider antifungal therapy while you await a diagnostic workup. Again, if negative, withhold antifungal therapy. If yes, you continue or you start antifungal therapy if you haven't. Alternatively, you can go down the route of an empirical approach where you treat refractory fever, but you should only use empirical therapy while you try to buy time to make the diagnosis. So you start empirical therapy and you send samples away for fungal testing, for fungal PCR and for antigen testing. And this just highlights sort of the benefits of such an approach. This is what we did in Cardiff, and what we actually found by combining PCR and galactoanalyzer, you had a really high sensitivity of around 100 or 98%, really high negative predictive value, and a really low negative likelihood ratio. So when PCR and galactomannan are consistently negative, you can exclude disease. Conversely, when both tests are positive on multiple occasions, a high specificity, so an average positive predictive value, which highlights the incidence of disease of around 10%. So the pre-test probability being 10%, going up to 55 to 60% when both tests are positive on multiple occasions. And this reflects the fact that the positive likelihood ratio is sufficient to confirm infection in your patient. And in our scenario in Cardiff, these biomarkers preceded specific radiological signs in 85% of our cases. And there are now multiple randomized controlled trials confirming the safety and efficacy of this preemptive or diagnostic-driven strategy compared to empirical antifungal strategies in hematology settings. We can also combine diagnostics for PCP, and this is PCP, PCR, and beta-glucan. And if you work your way through the algorithm, you can find that when you've got a PCP, PCR positive, the probability in a renal transplantation patient goes up from 2% up to 30%. And then when you combine that with beta-glucan positivity, you can actually see 68% positivity. In a situation where the tests are negative, you can see there's a really low probability that your patient has disease. And as I mentioned previously, burden of disease also increases the probability of pneumocystis. So in a situation where you have a low CQ value by your PCP, PCR positive, the probability goes up to 45% and 81% when combined with beta-glucan. If you take that further, and you say that you want a higher beta-glucan positivity threshold, and also apply that to the lower PCP, PCR cycle threshold, you can get a probability of 90%. And we're in a similar situation for the diagnosis of invasive candidiasis by combining Candida PCR and beta-glucan. So this is in a situation where there's a pre-test probability of around 10%. When you have a beta-glucan positive, that increases the probability to 30%. If we then combine that with Candida PCR, you can see that increases to 70% and even 85% if you use a threshold requiring multiple patients or multiple samples to be positive by Candida PCR. On the other side of the equation, when basically the tests are consistently negative, very low likelihood that your patient has invasive candidiasis. So concluding comments, know your patient. Does your patient have your classical risk signs? And so subsequently, could you expect them to have your typical clinical presentation? But be aware that our at-risk cohorts are growing, and that includes our hematology-oncology cohort due to the use of steroids, due to the use of monoclonals. Understand your test. If the result you're generating is not going to alter the management of the patient, why did you request the test in the first place? Both biomarkers and conventional mycology have benefits and limitations, but we're probably more aware of the benefits and limitations of conventional mycology compared to biomarkers. In mycology, perfect tests are rare, and more often than not, we are dealing with a diagnosis of probable invasive fungal disease, or in the clinic quite often probable invasive fungal infection. But really what we want to do is generate probability thresholds to actually turn probable disease to a probability to give us more confidence in diagnosing and treating our patients. Our protocols in microbiology need to be updated to focus on fungal disease, and we need to update our best practice guidelines. Consensus definitions for defining invasive fungal disease are not optimal for clinical use, fungal disease is more than just clinical or radiological presentation. And arguably, the original EORTC MSG definitions published in 2002 are better suited to clinical use. Combination testing is optimal, and we should use the full repertoire of testing, including conventional mycology, but we need to improve access to non-classical mycology. But overall, we need to improve surveillance of fungal disease, and in particular antifungal resistance, and we need to break the vicious circle that undermines the general perception regarding the clinical significance of fungal disease. On that point, I will stop. I'm not sure if there are any questions online, but if not, I will take them during the discussion session later in the day.
Wow, thanks very much, Lewis. That was fantastic. A really, really useful summary of the situation as it is now. I hope I can remember half of it. It was really great. Really, really useful. Thank you very much. There's one question in the Q&A now. If you're all right with us to, maybe we'll just address that one now and see what we, later on we can answer any others. So it's a specific question about PCP, or pneumocystis PCR from throat swabs, saying we only perform this on BAL and wonder whether you use quantitative test or just rely on the CT value to guide significance.
Yeah, so we use throat swabs as well as BALs and occasionally do sputums. The assay we use is semi-quantitative, so it is based on the CT value. But we have defined thresholds for our assay where we know, based on the underlying condition, whether it's HIV versus non-HIV, what is a significant value. So in our hands, it's about sort of 36 cycles in the so this is for a throat swab that's positive in the HIV negative patients, and about sort of 34 cycles in the HIV positive. So if you get a positive below that, the probability of PCP is really, really high. But what we tend to do is combine most of this with a serum beta-D-glucan. And to be honest, more often than not, both tests are positive in your patients. And if the situation where the tests are discordant, you start to query the diagnosis. But bear in mind, this is not 100%. These are not proven infections. And we have had patients who are positive by PCP-PCR and have a serum beta-D-glucan who haven't been treated for pneumocystis and are happily walking about today. Yeah,
great. Thank you. It's interesting to hear about your different cutoffs for HIV and non-HIV patients.
Yeah, it just reflects the burden. It reflects the burden in the lung and then the immune response in the non-HIV to the presence of pneumocystis, which is far more OTT, should we say.
Right. And we have another question here also about pneumocystis. What is the significance of checking pneumocystis PCR in blood samples?
It's actually, I never thought this was going to work, and I never did it. However, it's highly specific. It's about 95% specific for the diagnosis of pneumocystis. And there is a meta-analysis looking into this, and the sensitivity is around sort of 80%, 75, 80%. So if it's negative, don't use it to exclude. If positive, it's highly specific. Again, the way we use it, beta-D-glucan positive, risk factors for PCP. We then do the PCP on top of the positive beta-D-glucan, and if it confirms, great.
Okay, so it can be a useful test then.
Yeah, highly specific, non-SE sensitive.
Yeah, okay, great. Well, thank you very much. Really fascinating. So hello again, everyone. It's 25 minutes to the hour, so we're going to restart our webinar agenda now. I hope you had a good break, and thanks for rejoining us. So our next expert speaker is Dr. Ed Bevan. Ed is a consultant microbiologist for Public Health Wales Microbiology Swansea and honorary senior clinical lecturer for Swansea University Medical School. He undertook his specialist microbiology training as an academic clinical fellow at the Royal Liverpool University Hospital and gained a PhD for a thesis entitled The Molecular Epidemiology of BLA-CTXM Resistance Genes in the Fecal Microbiome of Humans Acquiring ESBL-Producing Enterobacteriaceae. So that is Ed's particular specialist field is resistance in gram-negative organisms. He's clinical lead for antimicrobial stewardship here in Swansea and has led out the rollout of antimicrobial stewardship ward rounds here. So I am really grateful to Ed for finding time to join us to talk about another one of the major challenges in microbiology, which is managing very resistant gram-negative infections. And he's going to bring us up to date on the latest in this problem. So thanks ever so much, Ed.
Thank you very much, Angharad, for the introduction. I think this presentation is going to build quite nicely on the presentation from Professor Wasif earlier on. So this is going to be more of a general talk about resistant gram-negatives and how we should manage them. Okay, so just to give you some background then, and this is probably not going to be news to any of you, but the World Health Organization a few years ago named 12 bacteria that pose the greatest threat to human health, and they categorized these in priorities. So priority 1 were the big 3 gram-negative pathogens that cause a problem globally, so Acinetobacter, Pseudomonas, aeruginosa, and then the family of Enterobacteriales. And I just added a quotation down there from the GLASS report in 2021. So carbapenem resistance in bloodstream infection caused by Acinetobacter species depicts a dire scenario. Okay, so just a quick overview of what I'm going to say then. So I'm going to talk about gram-negative infections generally. I'll talk about the clinical sources involved, which bacteria we're talking about, I'll cover again. And I will then focus on some resistance mechanisms, especially on carbapenemase producing organisms, or CPO. We'll touch very briefly on the epidemiology in Egypt, and then I'll look at some management pointers, antimicrobial management and infection control. So back to basics to a certain extent. I know it's a mixed audience. There may be people in the audience that are not necessarily microbiologists, so just starting from scratch really. So where do these bacteria come from? Where do gram-negatives come from? Where do they live? Well, they live within the gut microbiome. So this is the starting point. And they can be normal flora without causing any infection whatsoever. And then this leads us nicely on to, well, what are the infective sources of an invasive infection? And the best marker of invasive infection that we have is a bacteremia or a bloodstream infection. And so then we think of, well, anything that can go wrong in the gut, particularly the large intestine, whether that's abscess, perforation of some kind, that could be a source of a bloodstream infection with a gram-negative. And then any invasion to adjacent anatomical structures, so especially urinary tract infection, and also biliary tract infection. So these are foci of gram-negative bacteremia as well. We've also got to think about the hospital environment, though, and I'm conscious there is another speaker coming up. I was going to talk quite a bit in detail about infection control, so I'm not going to dwell on this, but contamination of the environment with gram-negatives from the gut, so fecal spread to the environment is a huge problem. And things that we do to patients, so if we use the Foley catheter, or if we put long lines such as PICC lines into patients, then these can become colonized and then sometimes infected with gram-negative bacteria. So patients may develop an infection that's sort of primary from their own flora, or they may acquire an infection from the hospital environment itself. And then just to reiterate, we're talking here about gram-negative bacteria, and the focus is going to be on Enterobacteriales family, which obviously includes E. coli, Klebsiella, and the resistance mechanisms that I talk about are also relevant to Pseudomonas aeruginosa and Acinetobacter species as well. So again, the microbiologists in the audience may be familiar with these concepts, but just to revisit. So what about the mechanisms of antimicrobial resistance then? The two broad mechanisms. Firstly, an antibiotic is prevented from reaching its target site. So it can't work, it can't kill the organism. Secondly, the target site in the bacterium is altered or changed, so that the antibiotic has no effect. And then this is a little schematic that kind of gives examples of those two main mechanisms of AMR. But the one that I'm going to focus on is over on the left-hand side here. So enzymatic hydrolysis of an antibiotic, because this is the problem globally. This is why the WHO has priority pathogens of gram-negative bacteria. It's because the big problems with resistance really come down to enzymatic hydrolysis of the antibiotic. So bacteria release enzymes which degrade the antibiotic before they can have any effect. So in simple terms, then a beta-lactamase. This is what I'm getting at. So an enzyme which breaks down beta-lactam antibiotics. The narrow spectrum beta-lactamases are easily inhibited by amoxicillin, clavulanic acid, or piperacillin tazobactam. And then if we move up a step, we've got these extended spectrum beta-lactamases. So these are enzymes which break down third generation cephalosporins and many other beta-lactam antibiotics. And with the ESBLs, as many of you probably know, the amoxicillin, clavulanic acid, and piperacillin tazobactam, while they may occasionally test as sensitive in the laboratory, are not always clinically effective or necessarily reliable. Up a step again, then, the ones that we really worry about as medical microbiologists, so carbapenemase producing organisms. So what is a carbapenemase? Well, it's an enzyme which breaks down carbapenem antibiotics and many other beta-lactam antibiotics as well. So we could refer to it as a broad spectrum enzyme because it degrades many different types of beta-lactam antibiotic and carbapenem. So a little bit more detail on the spectrum of enzymatic resistance. So at the top there, we've got these narrow spectrum beta-lactamases. So our TEM1 and 2 and our SHV1 enzymes. So these enzymes are very good at hydrolyzing penicillin and amoxicillin. And some of our gram-negatives, such as Klebsiella pneumoniae, have a TEM gene on the chromosome, and so that's why they're always resistant to amoxicillin. So we can never use amoxicillin to treat a Klebsiella. Whereas if we move up a step to extended spectrum beta-lactamases, now these have developed over the decades really since we've used more and more antibiotics in human medicine, and they've developed in two main ways. So firstly, they've become greater numbers of mutants of the original TEM and SHV enzymes, and through consecutive point mutations, you get a change in the active site, which can sometimes increase the spectrum of the enzyme, so it can degrade a broader range of antibiotics. So that can push them into becoming an ESBL, so they can degrade third generation cephalosporins. And then there's another big group of ESBLs, the CTXM family, and these are completely different to the TEM and SHV. So this is a new, was a new enzyme that was discovered around 1990. And it actually jumped via a transposon probably, or a plasmid, from an environmental gram-negative called Cloivera, and jumped onto a clinically relevant member of the Enterobacterialis family. And since then, this has become globally disseminated. And as many of you will know, CTXM producing gram-negative bacteria are really the main type of ESBL that we see globally. And as you could see from the data from the previous speaker, CTXM is obviously prevalent in Egypt as well. Obviously, if we've got problems then with ESBLs, we're going to have to use carbapenem antibiotics more often, and then that will drive the spread of carbapenemases. And these, as I mentioned before, these hydrolyze all beta-lactams, most cephalosporins, and carbapenem antibiotics. So this is data from the UK reference laboratory in London going up to 2019. On the top of the top chart shows the number of isolates referred to the reference laboratory with carbapenemase genes in Enterobacteriales. On the bottom half is the number of blood cultures referred to reference laboratory. And then if you just glance at the legend at the very bottom, you can see the different, there are many different carbapenemase enzymes and many different combinations that can be co-located on the same organism. But the take home really is that in the UK, there are 3 predominant carbapenemases that we see in clinical practice. OXA48 is probably still the most common, followed by NDM and then KPC. So these are just the names of the different carbapenemase enzymes. So why are carbapenemase producing organisms important? Well, and just to as an aside, we in Wales at least, we use the CPO acronym. That's what we've kind of decided on as our abbreviation, because it does capture all organisms, including the Pseudomonas and Acinetobacter as well as Enterobacteriales. So CPO are bacteria which are resistant to almost all antibiotics. So I'll come on to that in a little bit more detail shortly. So they can be carried in the gut of some patients without causing any symptoms at all. And carrying CPO means there is going to be a risk of getting an infection with CPO, and then a risk of passing CPO on to other patients and also to the environment. It goes without saying, if we've got resistance, in some cases antibiotics will not work at all, and in others the choice of antibiotic will be limited and usually less effective. And once a patient is positive for a CPO, at least in Wales and in the UK, then they are treated as positive for all future admissions, as the bacteria probably remain in the gut indefinitely, and we don't have any proven methods for removing them or decolonizing the patient. So what about other non-beta-lactam classes of antibiotic for treating CPO or ESBL producing bacteria? Why can't we give, say, an empirical fluoroquinolone or a aminoglycoside for CPO at-risk patients? And the reason to pose that question, particularly if there are any non-microbiologists listening, is that I've said that our carbapenemases will degrade carbapenems and beta-lactams and cephalosporins, but they don't degrade fluoroquinolones or aminoglycosides. So why aren't they effective? Why can't we use them? Well, the answer to that is co-resistance. So this is a figure which represents a plasmid from an E. coli, which was from the feces of a human acquired in India. So this was one of my travelers that I recruited that was traveling from the UK to India, and they acquired this E. coli, which was detected when they returned back home. And within the E. coli, we had this plasmid, which is a circular ring of DNA, which is, as you can see, it's about 116,000 base pairs. The reason of putting this up is that you can see, if you look at the left, on the left-hand side, top left of the ring, you've got these red bars that I've highlighted in red on the outside. And then I've also blown up some of the names of the genes involved, which are highlighted in red as well around the outside on the left-hand side of the slide. So the reason for putting this up is to say that these red bars on the outside each represent a different antimicrobial resistance gene. And so what I'm getting at is that plasmids carried by bacteria and also sometimes part of the bacterial chromosome can contain what we call these multi-drug resistant cassettes. And so if I go from top to bottom here, we've got genes that encode resistance to tetracyclines. We've got a TEM1, which encodes the amoxicillin resistance. We've got lincomycin clinder resistance. We've got aminoglycoside resistance. We've got OXA1, which encodes resistance to piperacillin tazobactam in particular. We've got a CTXM15, which is an ESBL, and we've got CAT, which is chloramphenicol resistant. So you've got here only one of the one of these ESBLs that I mentioned earlier, the CTXM, but co-carried next to that, you've got other genes that encode resistance to different classes of antibiotics. And due to evolutionary pressure, you know, if you apply an antibiotic to say, you give an antibiotic to a patient from one of these classes, then what you can do is select for this plasmid, select for this organism, which has multi-drug resistance to other agents as well. And so that's one of the reasons why we get the spread of these multi-drug resistant organisms in our patients and in the environment. So I'm going to touch a little bit on the epidemiology of AMR in Egypt. So why is that important? Well, as I'm sure you can appreciate, national and local hospital level data on the rates of AMR pathogens is essential in determining the appropriate empirical antibiotic regime. For example, for neutropenic sepsis in haematology and oncology patients. So we need to know what the data is locally so we can design the appropriate empirical antibiotics. And I found this paper from the Lancet, which was published last year, which did some a global analysis, really, did some modeling as well. And I just listed what their outcomes that they published for Egypt. And this was based on some raw data, but also on some modeling exercise that they did. According to this paper, they said that Egyptian data, they estimated % of isolates resistant. And you can see, I'm not going to read out each line, but you can see the resistance is very high there. So 3GC just refers to third generation cephalosporin resistance, which is a marker for ESBL production. And then you can also see we've got carbapenem resistance there and Acinetobacter up to 80%, also up to 70% in Klebsiella pneumoniae as well. So clearly issues with resistant gram-negatives being highly prevalent in Egypt, unfortunately. So moving on to the management side then, in my view, that there are kind of two main pillars of managing AMR. So one is antimicrobial stewardship, and the second one is infection prevention and control. So as I said in the previous slide, empirical antimicrobial choice is informed by local prevalence of AMR in the population, screening patients, and the way we screen for resistant gram-negatives is rectal swab for PCR ideally and culture, and then isolation in a hospital side room of patients who are high risk for AMR and gram-negatives. And then the risk assessment should be based on the patient type, acuity, the situation, and also the travel and hospitalization history in terms of risk factors for colonization with MDR gram-negatives. And then if you've got a patient at risk or even a patient that's confirmed to be a colonized patient, then you need to think about preemptive targeted therapy for those confirmed positives when they develop an infection or when they develop signs and symptoms of an infection. Infection control I'll touch on very briefly because I know there's another talk coming, but in the UK we do follow the World Health Organization guidelines on the 5 points of 5 opportunities for hand hygiene, and unfortunately it's not always done properly. One of our UK-wide national policies is bare below the elbow for healthcare staff. So this policy is designed to encourage and facilitate appropriate hand hygiene at all times. And we also enforce mandatory training for staff so that they have to complete infection control training every year and also have hand hygiene assessments every year as well to keep their skills up to date and accredited. So what about antibiotic options then for resistant gram-negatives? I'm not sure whether you have any of these available in Egypt or not. We have a few of these newer agents available in the UK. The ones on the left-hand side in green I've highlighted because we have access to them in Wales. The ones on the right-hand side in black, for various reasons, we don't have access to so far. So I'll kind of go through each one of these in turn. So what about ceftazidime avibactam? So this is a drug that contains ceftazidime, which is a third-generation cephalosporin. It's an anti-pseudomonal, while having a relatively broad spectrum. But it also includes avibactam, which is beta-lactamase inhibitor. And avibactam inhibits CTXM, also inhibits OXA48 and KPC, which, as I mentioned earlier, account for about 2/3 of carbapenemases in the UK. However, avibactam is not active against metallo-beta-lactamases, so that includes MDM, IMP, and VIM. And they're called metallos because at the active site they have a metal ion, so that's why they get the name metallo-beta-lactamase. And MDM is the commonest one in the UK. So the FDA approved indications are complex intra-abdominal infection, complicated UTI including pyelonephritis, HAP, VAP, and also infection from gram-negative bacteria in patients with limited treatment options. So what about ceftolozane tazobactam? So ceftolozane is a newer cephalosporin. The main role is against Pseudomonas, and tazobactam is a different beta-lactamase inhibitor, which also inhibits AMP-C enzymes as well. And this is approved for complex intra-abdo infection, complex UTI, HAP, and VAP. So it does cover ESBL producers, but does not cover the KPC or NDM carbophenamases. Moving on then to imipenem relebactam. This is not one that I've used before, not available in Wales at the moment. This one is active against Enterobacteriales, Pseudomonas, and will cover producers of ESBLs, AMP-C enzymes, and also the KPC carbophenamase, but it's not active against OXA48 or NDM, and it's not reliable against Acinetobacter, and that's probably because Acinetobacter baumannii usually has an OXA enzyme present. Meropenem verbobactam. So this one is available to us locally. And this is very much a anti-KPC antibiotic. So verbobactam is a beta-lactamase inhibitor that's been designed to inhibit KPC specifically. It's no good for metallo-beta-lactamases such as NDM, and it's no good for OXA48 either. The EMA indications are complex UTI, complex intra-abdominal infection, HAP, and VAP. You can see the pattern developing in the approvals for these indications for these antibiotics. Because as I said at the start, and if you think of focus of gram-negative infections, then if you're trying to develop an antibiotic, you want it to work for urinary tract infection, you want it to work for intra-abdominal infection, and you want it to work for those patients that develop these hospital-acquired infections, which can be gram-negatives, like hospital-acquired pneumonia or ventilator-associated pneumonia. So this one, as I say, is for KPC producers only, really, and it's an alternative to ceftazidime avibactam. Moving on then to cefiderocol. So this is an advanced generation cephalosporin. And we do have access to it in Wales, and it's active against Enterobacteriales with ESBLs, AMP-C enzymes, KPC, NDM, OXA48. It's also active against Pseudomonas aeruginosa, Acinetobacter, and also Stenotrophomonas multifilia. The trade name is quite interesting and actually helps one understand the mechanism of action. This is it's known as a parenteral siderophore cephalosporin, so it's IV only. And the mechanism of action is that the antibiotic hijacks the ion uptake pathway in the bacterium. So siderophore is an ion channel, and iron is essentially a nutrient source that the bacteria need to survive. So the antibiotic uses that channel to gain access to the bacterial cell. And so it's sort of a Trojan horse approach that this antibiotic is taking. There was a phase 3 RCT published in Lancet ID, and this showed clinical efficacy against best available treatment, but it was quite heterogeneous population and only 152 patients randomized. There was also a warning from the trial that there was a higher all-cause mortality in the cefiderocol group compared to best available treatment, but that wasn't statistically significant. And then just to mention this one, which isn't available anywhere yet because the trials are still ongoing, but this one is called Aztreonam avibactam. So it's currently undergoing phase 3 RCTs. So why combine these two antibiotics? Well, Aztreonam is a monobactam, and the reason why this is quite a useful drug in the context of MDR gram-negatives is that Aztreonam is not broken down by these metallo-beta-lactamases, so these carbophenamases that have the metal ion at the active site, such as NDM. However, Aztreonam is broken down by CTXM ESBLs, and as I've explained, you often get this co-resistance of genes sitting next to each other and enzymes co-produced, and I think that came out quite nicely in Prof. Wasif's data earlier on today, in that many of the bacteria, the carbapenemase producers in your hospital seem to have both NDM and CTXM in the same strain. And so what you need, if you're going to give aztreonam, you need to protect it with a beta-lactamase inhibitor. So they've combined aztreonam with avibactam, which protects the aztreonam from hydrolysis by the CTXM. And aztreonam is already stable to the metallobeta-lactamase. And so this is hopefully a promising new therapy that's targeted towards the metallobeta-lactamase producers. Moving on then to novel tetracyclines, so amadacycline and iravacycline, not drugs that I've used before, we don't have them available in Wales. They're active against KPC and NDM producers. They actually have quite a similar spectrum of activity to tigecycline, which we do have locally, but the MICs are lower, looking at the data on these drugs. So they're not active against Pseudomonas or some Enterobacteriales, which I've listed there. So there are some organisms which we would never cover with these antibiotics. And it's notable, iravacycline was non-inferior to a carbapenem in phase 3, a randomized controlled trial of patients with intra-abdominal infections, as you can see there listed. And it's notable that this was not used. The RCT did not include patients with complicated UTI, so these antibiotics don't get into the urine very well. Just to comment then on polymyxins. So what about polymyxins? So these include colistin or polymyxin B for resistant gram-negative infections. So there is historic clinical experience where colistin plus a high-dose meropenem has been used for carbapenemase-producing organisms. However, this has lost favour due to the toxicity concerns with colistin. And there has been some unfavourable data that came out of Lancet ID a few years ago that demonstrated combining colistin with meropenem was no better than colistin monotherapy in terms of treatment failures. However, the caveat with that data is that 77% of infections in that study were due to Acinetobacter. And the trial was not powered to address efficacy against KPC producers or Pseudomonas. And so locally and in the UK, luckily, Acinetobacter is not highly prevalent. Certainly multi-drug resistant versions of Acinetobacter are not. We're more concerned with Enterobacteriales and occasionally Pseudomonas. So we've got to take that data with a slight pinch of salt, really. The problem with colistin monotherapy is we know that we get rapid selection of mutant-resistant subpopulations, both in vitro and in vivo, and therefore we always want to give it with a second agent to prevent that happening. There has been resistance described in colistin, so probably heard of the plasmid-mediated MCR1 gene, but also we've got to remember the intrinsic resistance found in some gram-negative species against colistin, which I've listed there. So we've got Serratia, Proteus, Providentia, Morganella, and Burkholderia as well. So I'm kind of coming towards the end of my talk, but I just want to kind of think about those really sick patients. So imagine a patient has septic shock. Which agents should be used empirically when you want to cover gram-negative infections? Well, it goes back to the local epidemiology and hopefully referring to your up-to-date local antimicrobial guideline based on that epidemiology. And then thinking, well, does the patient have a history of or risk factors for carbapenemase producing organism carriage? And then also thinking about, well, how unwell is this patient? Can they wait for diagnostics? If they're in septic shock, obviously not. And also then to consider combination therapy until microbiology diagnostics are back. So giving something broad, probably do a gram-negative cover until you've got some diagnostics back to guide you further and until the patient is stabilized. So which agents should be used empirically? And I think we're probably moving to a future where we're going to have more and more rapid diagnostics. Certainly in Wales, we've got Cethid platform and BioFire platform in most hospitals. And I note from Prof. Wassef's talk earlier that those are the platforms you've got as well. And the advantage is, obviously, you can get a genotype hours or sometimes days before you get phenotypic sensitivities. And so I think in the future, we're going to be using genotypic testing more to guide therapy. So using Klebsiella pneumoniae as an example, given different genotypes, we're going to be able to choose a different antibiotic regime. So on the top, I've got Klebsiella pneumoniae that's only got a TEM, say a TEM1 gene. In theory, you could treat that patient with ceftriaxone or amoxicillin clavulanic acid. If, however, you've got a Klebsiella pneumoniae with CTXM, you're going to have to use an antibiotic that's stable, it's not degraded by CTXM. So then we're moving up to carbapenems. Moving down then, if you've got Klebsiella pneumoniae with a KPC carbapenemase, then you can't use your carbapenem or your ceftriaxone because they'll be degraded. So we'll need an antibiotic that's stable that will inhibit potentially the KPC. So ideally, ceftazidime avibactam, that's probably the one we would choose locally in Wales, but there are alternatives as I've listed there. And then on the bottom, so what if we've got a metallo-beta-lactamase? So more of our nightmare scenario, certainly in Wales, we don't see too many of these, but when we do, it's definitely a clinical nightmare. And then we've got to think, well, can we deploy cefiderocol? Problem with that is anecdotally, we're seeing where we do get NDM producers, we're actually seeing resistance to cefiderocol as well in those organisms. Or do we do something like combining ceftazidime avibactam with aztreonam to give us that aztreonam avibactam combination in advance of that particular drug being available commercially and for patients. And then I think this is my penultimate slide. So I've just put a report here. So this is one of our reference laboratory reports of Klebsiella pneumoniae with the phenotypic data on the top there. You can see we've got options listed based on that list anyway. We've got cefiderocol was reported as susceptible, and also ceftazidime avibactam. The genotypic testing showed that we had an OXA48 like carbapenemase. So for that particular organism, we probably, if there was a clinical infection, we would have chosen ceftazidime avibactam. I think this is my last slide, and I just wanted, I couldn't talk about gram-negative resistance without talking about the underlying issues at play, and if we're going to tackle this as a global community. It was all about the One Health approach, and this is about tackling resistance in lots of different ecological niches. So We use antibiotics in human medicine, in agriculture, in veterinary medicine, and unfortunately the gram-negative bacteria will survive and thrive in all these different niches. So we need to tackle the problem. It needs to be a multi-pronged approach, really. So thank you for listening. I'm happy to take any questions. Just to acknowledge some of my colleagues who also work in Public Health Wales, Mandy Wootton and Howard Davis, who you've met today, and Julie Harris, who's one of our consultant pharmacists in Swansea.
I'm just trying to show my video again. Here we are. Right. Thanks very much, Ed. Absolutely great. A really helpful summary of the state of the art and the situation at the moment. Really, really useful. I can see that Professor Wasef has her hands up, as well as we have a question in the Q&A. Professor Wasef, did you want to make a comment or ask a question?
Can I ask now, or
Yes, yes.
On to, okay. I have two questions for Dr. Edward. The first about the use of fosfomycin in treatment of MDR, because as it mentioned in the CLSI, it can be used only for uncomplicated UTI caused by E. coli only. But our physicians usually asked us to put fosfomycin susceptibility test in the results even of Pseudomonas. They like to, because there are many literatures that mention that fosfomycin can be successfully, can treat successfully the Pseudomonas. This is the first question. The second, which is the question of most of our physicians, what about the role of MIC as a guide to treat carbapenem-resistant organism? I mean, if meropenem is resistant, but MIC is less than 16, so I still can use meropenem in treatment with a combination of other carbapenem or combination of aminoglycoside, for example, or you don't advise to use carbapenem at all, even if you have a low MIC, or to follow the breakpoints as a guide for the MIC to treat your carbapenem resistant strains. That's my two questions.
Okay, yeah, I'm happy to pick those both up. I'll start with your last question first. Generally speaking, I wouldn't be happy to use meropenem if it's testing as resistant. If it's testing as sensitive, but you know that genotypically there's a carbapenemase gene present, again, I wouldn't really be happy to use it if you've got an infection present. But I think it really depends on the situation with the patient that you're faced with. Because say now you've got a patient that has, I don't know, an intra-abdominal abscess, which you've drained, and you've grown the carbapenemase producer from the deep sample, then that's the bug causing your infection. I'd be very reluctant to give meropenem then, even in combination with another antibiotic. On the other hand, if you had a patient where maybe they were just colonized on the rectal screen with a carbapenemase producer, and you had the same situation where it was coming out as testing as sensitive, that often happens with OXA48 rather than NDM. And if your patient, say, is not particularly unstable, maybe they've got a low-grade temperature, then in that situation, I'd be less worried about giving meropenem, say meropenem and colistin, or meropenem and tigecycline, or whichever combination you choose. just because the stakes are less high and you don't really have a confirmed infection, you've just got colonization. So I think it kind of depends on the situation, and certainly that's how we approach that question in Wales. So it's kind of tailored to the genotype and also the clinical scenario in front of you. And then your first question was about Pseudomonas and fosfomycin. I haven't done that personally, but I have heard it being done. I didn't mention fosfomycin in my slides, and perhaps that was a bit of an oversight. We do sometimes do MIC testing, or at least they do in our reference laboratory in Cardiff for fosfomycin. I've seen that done for Enterobacteriales. I'm not too sure whether they would for Pseudomonas. They probably would if asked. I've personally used fosfomycin once when I was a registrar in Birmingham, and that was in combination with meropenem. I think it was an OXA48 producer. So it was IV fosfomycin with meropenem. I wouldn't use oral fosfomycin unless it's just a simple UTI. I hope that answers your question.
Thanks very much, Ed.
Thank you.
Fantastic.
Thank you so much.
We have got 2 other questions in the chat, but actually, so that we don't fall behind with our schedule, we'll take those in the panel discussion at the end. Are you okay to hang around for that, Ed?
Yeah, that's fine.
I know you have to leave us at 2 in
Yeah.
UK time, but
Yeah.
I think there'll be time.
Thank you.
So we'll come to those 2 questions. I can see this. We'll come to the 2 questions in the panel discussion. Okay. So we now come to the last of today's formal lectures, and for that I am really delighted to welcome Dr. Manjula Mehta. Dr. Mehta is a consultant clinical microbiologist and infection control doctor at Frimley Health NHS Foundation Trust, and she's also the secretary of the Healthcare Infection Society, which some of you may be familiar with. She's got a wide experience of managing many large infection prevention and control incidents and outbreaks, and published widely in that field. And she's particularly interested in IPC in the built environment and managing incidents around water safety in healthcare. And today she's going to talk about IPC, or infection prevention and control considerations in managing CPEs and other multi-resistant gram-negative organisms in Haemato-oncology units. Thank you very, very much for your time joining us, Manjula.
Thank you, Prof. Davies. I'm just going to share my screen now. Okay, I hope my screen is visible. Okay, so good afternoon, everyone. I am like Prof. Davies said, my background is that I work as a clinical microbiologist and an infection preventionist in a rather large hospital, which is about 1,700 beds, but it is spread over 3 acute care trusts in Surrey, which is just outside of London. My talk today will be on infection prevention aspects of management of CPE, especially in Haemato-oncology units, and the role of the built environment in the transmission of such bugs. I'll start with an icebreaker. We all know why scientists look for water in the universe. It is because water is the essence of life. And to keep water free of microorganisms requires knowledge, energy, and a lot of resources, unfortunately. So I'll describe a recent outbreak investigation that we undertook in one of our hospitals, when actually we noticed that one of the main water pipes supplying the hospital was leaking. And in its close vicinity was also a drain that was leaking. So clearly we were worried that there may be some mixing of drain water with mains hospital water. And we wanted to investigate this further. We also knew that in this particular hospital, which we call Hospital A for the purposes of this presentation, and you can see in the pink bars here, had higher rates of CPE over the last 12-24 months, and this was creeping up. And this was compared to one of our other hospitals, Hospital B, which is also of a very similar size, and the infection control practices across these two hospitals are really the same. So I'm not going to go too much into it because this has already been nicely dealt with the previous talks. So we know that we carry millions of gut in our bacteria, and some of these bacteria then can acquire these genes, which are called CPE genes. And once they acquire these genes, these carbapenem antibiotics that they should be effective against become ineffective. And we know that this is becoming an increasing problem. And we know now that antimicrobial resistance, the number of patients who die due to antimicrobial resistance is more than that of HIV or malaria. And by 2050, the UN predicts that this could overtake the death toll of cancer. So it is a very growing and staggering problem. So how do we acquire these CPE bugs? So if you imagine that a patient walks into hospital and they're carrying a multitude of bugs, obviously, that are resistant to narrow spectrum antibiotics, and within the hospital environment, they happen to catch one of these CPE superbugs. This bug can remain dormant in these patients for several months or years, and we know that this is called colonization. And if colonization is then given antibiotics to treat, say, for example, an uncomplicated infection, such as a UTI, these antibiotics would clear the susceptible bacteria, and then your CPE begins to predominate. And in susceptible hosts, such as Haemato-oncology patients, this can lead to an infection. When staff dealing with such patients or patients themselves a shower or a sink, they can transmit these bacteria into the drains. So we started investigating this by looking at the timeline of all the cases that we have seen. Each from this quite complicated table here represents a patient, and each column represents time in months over a 2-year period. The colored cells represents the ward area in the hospital where they were being admitted to. So the red and the blue symbols here tell us which type of CPE and which type of bacteria the patients were colonized with. The green, here the red is, I think, the oxaloate, and the blue ones indicate NDM. As you can see here, there are a lot of green cells, and these were patients in Haemato-oncology wards, and cluster of cases in Haemato-oncology wards. We also saw a cluster of cases in what you can see, these pink cells, which was a medical ward or an endocrinology ward. And there was, sorry, I'll just go. So there were also some cases in IU and the brown cells. And sorry, let's go up here. These yellow bars here represent the isolates that we sent away for typing, and they came back identical, which told us that there was cross transmission happening between patients.
Dr. Neda, I'm sorry to interrupt a minute. On my computer, you're coming through very faintly. I don't know if that's only from me. I wonder if you can you get any nearer to your microphone, or maybe just speak very loudly, because I can't hear very well. Thank you.
Is this a bit better? I'll try and speak a bit loudly.
Yes, I can hear better now. Thank you.
Okay. So what we did next was we looked at the drain blockages in the hospital, and this is a heat map of all the blockages that happened in the hospital. And these are numbers that represent wards here. And as you can see, the highest number of blocks that we saw were in this area in the south of the hospital, which was Haemato-oncology ward, here, which is the intensive care unit. And these are the endocrinology wards. This sort of was similar to the cases where we were seeing with CPE, whether it was on screening or on clinical samples. So, so if you look at what we already know about the transmission of CPE, one of the things we know that there is a 2 meters around sinks. So when you use sinks, we know that bacteria gets dispersed, and anything within a 2 meter zone can get contaminated. We also know that bacteria can travel up U-bends and drain pipes at rate of 0.5 centimeters per day. So if one is colonized, we know that the CP days into it and get colonized with the CPE organisms as well. Not only that, because of the splashing that occurs when you wash your hands or when you do other things in the sink, you know that transmission of bacteria can occur from the drains into the periphery of the water system, that is into the taps of the water. And this can also happen, for example, we have observed this in our hospital when cleaners, when there are new cleaning staff who are not being trained appropriately or who missed their training, they come and clean the sinks and they use the cloth to wipe the drain, and then they go to the tap with the same cloth. So you can transmit these bacteria from the drains into the periphery of the water system. So it's very difficult to keep the water system dry. Okay, so there's also the slow drainage sinks, which can exacerbate flushing. As you can see here, this sink on the left is very poor design because the water is hitting the drain directly, which means, you know, the water can flush into the tap and into the surrounding environment. Because the water is not draining very well, you know, splashing is again more common. The sink here on the right is supposed to be of a better design because the outlet, the drain outlet is at the rear, and therefore splashback into the tap itself is to be less. However, the problem with this sink is that, you know, it has a sieve that stops material such as, for example, here there's an EDTA tube and this razor and all kinds of other material that can go down the sink. And once the sinks get blocked with this material, you know, that itself exacerbates blockages and splash back in the sinks. And what we also know from study now is that when you add organic matter into drains, it helps the proliferation of biofilm growth. So bacteria will grow up into the drains and up to the sink sieve itself faster when there's organic material present in the drains. So this is a study that looked at the reasons why a hand wash sink is used. What they did here was they used a video camera on top of a sink and they recorded and analyzed what purposes a sink is used for. And you'd be surprised to note that hand washing is only 4% of all activities, and majority of other activities were activities such as discarding medicines or discarding food. So it's not surprising, therefore, that, you know, it's very difficult to keep these sinks and drains free of, I mean, not free of microorganisms, but even keep them in a state where, you know, we can maintain them adequately without risking contamination of the environment. This is another study by Professor Gormley in Edinburgh. And what he showed in his lab was he added Pseudomonas putida as an indicator organism. This is a lab setup. And he added Pseudomonas putida into one of the drains. And what he could show was in a parallel drain, he could detect Pseudomonas putida in a toilet that was connected to a parallel drain, but this was upstream. And he used air sampling and contact plates. And what happens here is that bacteria are traveling up these drains by an effect called the stack effect, which means that as fecal material or the drain material moves down the drain, you have movement of air upwards, which carries along with it microorganisms that can then travel up through the toilets or the sinks and cause a plume actually or an aerosol, which then disperses into the environment. And this is another study from Hong Kong during the COVID pandemic, which what I showed here was this is a multi-story building, and what they had was, you may have read this study already. They had patients in lower floor, and what they found was they had patients in the upper floor acquiring COVID, and given stringent isolation guidelines that was in place in Hong Kong during the time, they found that the transmission route was through aerosols again to the drains, and this is how I think the transmission happened of COVID from lower floors. putting all of this into clinical context, a large German study recently showed that they looked at infection rates in ICUs over many hospitals. And what they found that hospitals that had a sink in the room, in their patient room, had a higher risk of hospital-acquired infections than in intensive care units that have a sink in their patient room. And of course, you'll be familiar with Dr. Drew's study, where he showed that the only way they could eradicate very resistant gram-negatives and CPE from their hospital intensive care unit was to create a water-free patient environment. So we looked at what was happening in our own hospital and in the Haemato-oncology wards and some of the other wards. And what we found was, these blue trays here, they're used for patient medicines. They take IV drugs or other medication on these blue trays. They take the patient, the medication is administered. They bring it back, and they were washing in these sinks, and they were letting them to dry on the side. Clearly, these were prone to contamination because there's definitely droplets of water landing on these blue trays, and this is going directly to patients. We also found that there were wrong these small sinks, and as you can see directly on the drain itself. What we also saw was that this is a chemotherapy room, day room, and patients were receiving chemotherapy in very close vicinity of hand wash basins, and we had drug cupboards, in very close vicinity of hand wash basins as well. And this is very common in many NHS hospitals in the UK, but hopefully things will change as these risks are being recognized more widely now. And this is again, this is actually an intensive care unit where we had compromised patients, and we had a sink in one of the patient bays, and we have here drugs being made up right next to the sink. And here again, in one of the other wards, you've got hand towels, you've got wipes, you've got gloves within the vicinity of a sink. And then we also noted that you've got some sinks there's a leak in the drains. And then we were also unfortunately storing some cleaning equipment right underneath the drains. So clearly, there is risk of contamination of these equipment that are used for cleaning, and you can see how dissemination of these bugs can occur. And this is the dirty utility room where they get all patients' urine or stool samples, and they put it into macerators. But what's happening here is you're also storing clean equipment, and this is a clean commode seat that is very close to sinks. And here this is the utility room. You can see, the sink is in very close contact with this treatment trolley with IV fluids. In a regional hospital, they have reported an outbreak where they found that nursing staff were using the jugs, and the water was being filled up by leaving the jug in the sink itself. And what they noticed then was they were transmitting bugs from the floor of the jug into the patient environment. And this can happen whatever other equipment you're using, whether it's a wash bowl or any other equipment that you use near sinks. And also, if you don't have good hand wash techniques, for example, we've got elbow operated taps in most of the places in our hospital, but staff do not use the elbow operated taps as elbow operated taps, and they use their hands. So they wash their hands and they use the same hand to close the tap, which means that they're picking up the bugs from the handle itself. And what's also been shown is the gowns that you wear can get contaminated clearly by water droplets. And for example, if this is a new intensive care unit and there's a staff member washing their hands next to a tap with a gown on, you're then going to babies with contaminated water. And this is not just with CPE. I think CPE is just a marker organism because we can trace them. This would be true for any other gram-negative as well. As the German study showed, the incidence of all healthcare associated infections, whether it was CPE or sensitive organisms was higher in patients who had a sink in their room. So this is so what we did also was so we used settle plates, and as you can see here, this sink has the velocity of water is very high and it's not draining very well, and there's a lot of water droplets you can see on clean equipment that is being stored around sinks. And we also took a lot of drain samples. We also placed settle plates in and drains. And what we found was that clearly, the drains had CPE, but the in the main drain itself. But in the sinks, we found about 26% of the sinks had different types of CPE, and some sinks had more than 4 types of CPE. This very poorly draining sink that I showed you before had at least 4 different types of CPE. As you know, there's different levels of control. There's hierarchy of controls, from the most effective to the least effective. TPE and administrative controls, such as education and training, are least effective, as you can imagine why in this case, in this kind of an outbreak. So what you're left with is engineering controls, substitution, or elimination. And elimination is what they did in the Netherlands unit, where they went water free. But what else can you do to control these outbreaks than having to go radical, than taking all the sinks out or going water free? We looked at drain disinfection methods, such as chemical disinfection, steam, and there's also thermal drain disinfection and UV drain disinfection. We looked at the literature. We spoke to a lot of colleagues who had used these techniques, and we know we had used such techniques in a different outbreaks, and we were for us it had not been effective. And clearly, thermal drain disinfection and using UV are not very expensive, so really expensive. So because there is a paucity of evidence at the moment to support these disinfection methods, we've not gone down and used these methods in our hospital. What we did do was we took some of the sinks out in critical areas. So this was, for example, that sink that you saw with the blue trays. This is a treatment room. So we took sinks out in a treatment room. You don't need sinks, right? Everything in there should be clean. So you're making up drugs. You don't need sinks. So you can use alcohol hand gel for disinfecting your hands. So we took sinks out of all treatment rooms. We took drug sinks out of drug storage areas, because again, you don't need sinks in there. We took sinks out in some of the clinical rooms where there was drugs being made, and there was no need for a sink to be present. And we also took sinks out in patient bays where we thought was not necessary. And there was another sink in close vicinity. What we also did was we looked at our drainage drain blockages, and we did a survey of the drains, and we found quite a lot of blockages in the south of the hospital. These were blocked with paper towels and lime scale. So we got all of these cleared, and these yellow dots represent the areas where we were having some of the outbreaks. We also looked at antibiotic use, because we know that antibiotic pressure causes increased antibiotic use causes a selective pressure on CPE. And what we had found was in Hospital A, which in 3 cases did have an increased use of meropenem compared to Hospital B. So we put antibiotic stewardship measures in place to reduce meropenem use in Hospital A. And as you know, you may know, the CPE screening guidance in the UK at the moment is to screen all patients who have known history of CPE, or if they've been in contact with someone with CPE, or if they've been transferred from other acute hospitals, including from hospitals abroad or within the UK, where there is an increased incidence of CPE, and also patients in renal dialysis, critical care, Haemato-oncology. These are the augmented care units. They require CPE screening. They're recommended to be screened as well. In addition, we are doing weekly admission and weekly and discharge screening in some of our high risk areas, and also vascular and endocrine wards. What we're doing for the CPE is we're using the multiplex PCR method, which detects those key enzymes. And like in Egypt, like the slides I saw previously, we've got OXA48 and NDM predominance as well. So it does detect the most prevalent enzymes that we have here. And we use either a rectal swab or a stool specimen for screening. And we also recommend that any wounds, any chronic wounds or urine samples, we also send for CPE screening. And that is because when you may remember, I showed you this slide, and what we had found was obviously there was more cases in hematology and ITU wards. And this we thought was, okay, we're screening more number of patients here. That's why we are detecting more patients. But why are we detecting so many cases on endocrine ward? And it became evident to us when we looked into the wards and the practices that these patients had skin ulcers and chronic wounds. And what they were doing was they were using the shower to clean these wounds. And obviously, the shower is very close to the drain. And so what we also did was we changed practice from cleaning wounds in the shower to cleaning wounds with sterile water. So we put a whole other raft of other measures in place, and we recommended use of alcohol hand gel. Now that is the practice throughout the trust after hand washing practices, and to use all equipment such as those blue trays, for example, with wipes, and like I've said, sterile water for wound management. And there's also a lot about sink etiquette. That is, you keep a 2-meter area around sink clear of equipment as much as possible. You try and remove sinks that are not necessary following a risk assessment process, and a move towards curtailed water solution, in the sense that it's not entirely water-free care, but you look at every process which uses water and you risk assess whether is that really necessary? Can I do it with something which does not need water, and so on. With the drains, we are now reviewing all our drains regularly, the drain blockages, and we encourage staff to report any blockages, and we are trialing flushable wipes instead of the normal wipes, which are clogging up our drains quite frequently. In the dirty utilities, we are reassessing flow and the storage of equipment. Obviously, we are training a lot of patients and staff on how to clean patient equipment. And screening, like I've said, we have enhanced CPE screening in hospital, and we're working on antimicrobial stewardship as well. So what's happened? What's the result of all of these interventions? So the black bar here shows when we started the screening process. At that time, we were detecting about 1 in 4 patients who were admitted to those critical wards with CPE, including the Haemato-oncology ward with CPE. I mean, what we need to know here is, the colonization is like a tip of the iceberg. So if you detect 100 patients who are colonized, there may be 1 case who goes on to develop an infection. So when we did the enhanced screening, we saw that about 20% initially. When we moved to cleaning with sterile water, the incidence dropped in those wards to about half the number of cases. And when we started removing the sinks, that was when we started removing the sinks. Clearly, there's many other infection control interventions, like I've listed before, that were also happening during this time. It's now dropped to quite excuse me, to low levels, and we see now a trickle of cases. But obviously, there's a lot of work to be done to manage this outbreak. And managing these outbreaks, as you know, is not expensive. Is not cheap. It's this paper here from London showed that the cost of managing the CP outbreak was about 1.1 million euros over a 10-month period. So it needs a lot of resources, unfortunately. And when we looked into a couple of our patients who would acquired CPE infection, as you will know, the drugs itself are very expensive and runs into hundreds of thousands of pounds. So putting in infection control measures in place to control outbreaks makes economical sense, because ultimately you will be saving a lot of money. And these are, as we've seen in the last speaker's slides, the CPE incidence is going up both in the UK and in Europe and elsewhere globally. So I think we need to really ask the question: are we in the next pandemic already? And these are some of the ideas that we've given to our clinicians on how, because it's really everybody's responsibility to control this outbreak, and what every clinician, whether it's a doctor or a nurse, can do, or any other healthcare worker can do to prevent CPE transmission within healthcare. And this includes the use of antibiotics judiciously, using diagnostic tests within microbiology, so infections are diagnosed appropriately, and if infections are not present, to stop use of antibiotics, using alcohol hand rub after hand washing, and using sterile water for washing wounds. And the sink etiquette, like I said, keeping a 2-meter area around sinks free of equipment, avoid discarding your coffee or food into sinks, reporting any blockages to estates, clearing any storage underneath the sinks that can get contaminated, and to review every source of water that is used in a unit, and to eliminate it if possible. And clearly there's a lot about patient education here as well, about not storing their, for example, their toothbrushes around the sink, and about not throwing paper towel down the drains. And I've said already about screening, and I think those with ulcers, open ulcers, and urinary catheters we've found are the ones that are highest risk of disseminating these organisms to other patients, and also acquiring it themselves from drains and wastewater systems in the hospital. And we try and isolate patients with CPE, or we cohort them as much as possible. And ultimately, you need sound infrastructure, ventilation, water, drainage, and adequate isolation facilities in every new build and refurbishment. Because if you get this wrong, obviously it's very difficult to fix afterwards. So my key points here are that there is increasing awareness of CPE that is required, and an understanding of the risks of wastewater in hospitals. Current guidelines, as you know, for the management of CPE outbreaks requires updating, because many of these risks are not identified in these guidelines. Enhanced screening is required to identify patients colonized with these pathogens. Like I've said, the number of colonized patients far outweighs the number of cases that we're detecting. And these infection risks, it's best to engineer them out rather than trying to do education and training around these risks. So there's a whole number of people involved, who have helped, who have assisted in managing the outbreak, and who are involved in further research and work from this piece of work that we've undertaken. Lastly, I'd like to draw your attention to this training that will be launched by the Healthcare Infection Society, which I'm part of, and it will be on water safety in healthcare system. It is meant to be, it's aimed at everyone involved in water safety in healthcare, whether it's an engineer or a contractor or an estates person, because they need to understand equally the systems that need to be in place to prevent transmission of these bugs from our wastewater systems and our periphery of our water systems to patients. Many thanks. I think that was my last slide.
Thank you very much for that presentation. Really, lots of useful advice in there. And that course that you've just mentioned, that's online, right? Yes, it's an online 3-day course. There will be an advanced course to follow, which will be face-to-face. But yeah, this course that will launch next April is an online 3-day course. So please do register your interest with the healthcare infections. So that's obviously accessible for anyone anywhere in the world then, in that case. That's right. Yeah. Excellent. Okay, well that's useful to know about as well. Thank you very much. So we've come to the end of the formal talks. We're now going to address any questions that have come in the chat, and in the Q&A, and I also have some questions. So I'm going to start with the ones here in the Q&A. I think most of these are at the moment aimed at Ed. I think lots of people want to know how to manage gram-negative infections, Ed. The first one is, why are the majority of NDM isolates resistant to cefiderocol, even though it's been widely marketed as being a wholly new agent for this resistant mechanism? And yet we see them resistant on quite antibiotic-naive patients.
Yeah, I don't fully know the answer to that, but all I can say is that in discussing this issue with SACU, which is our reference laboratory in Cardiff, so they do our susceptibility testing for cephaderical, and using the UCAST breakpoints, it seems like anecdotally most of our NDM producers are coming out as resistant to cephaderical. That's not to say there aren't some that are sensitive, but I don't have the confidence to use it empirically where there's an NDM or where there's a risk of an NDM. I mean, I think the marketing was probably done before that was known about, to be honest. I'm not sure, to be honest, I'm not sure about the mechanism of resistance. That's something I need to look into. But yeah, it's an interesting one and slightly disappointing at this point in time.
Which goes on to the next question, which is the best option for MDM if we haven't got aztreonam or cephaderical?
I mean, from experience, what we do then is if we think it's a confirmed infection clinically, and I mentioned a kind of intra-abdominal abscess as one example, is definitely there, or maybe it's even a bacteremia, then we'd be resorting to ceftazidime avibactam plus aztreonam to try and get that aztreonam avibactam combination, which is obviously an unlicensed approach, but tends to be successful from experience.
Okay, and there's one other here. Can we just use the antibiotic susceptibility results to screen for ESBLs and resistance pattern?
Yes, you can, but hopefully, given all the different agents that I mentioned, it's important to know what the mechanism is when you're choosing the agent.
Yes,
that's particularly true for the carbapenemases, but yes, you can, and routinely, if we're just talking about ESBLs, that's what we do in Wales, is we use cephalosporin as the screen, and the other cephalosporins as well, but predominantly cephalosporin. So yeah, that's our marker locally for ESBL production, and we don't routinely send it away to test for, a TEM or SHV or CTXM. But I guess the reason to talk about all of those is because on the BioFire platform, and I'm sure other platforms in future, we'll have more genotypic data. So
yeah. So here, like you say, it's been standard not to have to do that for ESBLs, isn't it?
No,
but one of the things that I wanted to ask you about was how critical do you think now in a modern day lab is the availability of genomic testing, or at least genetic testing, to get the mechanism of resistance in carbapenemase producers for optimizing therapy? Do you think that will be routine in all clinical labs very soon?
Yes. So in Wales, imminently, we're going to have this rolled out. So for blood cultures, we're going to have molecular testing with the BioFire at the hospital site where the patient is. So in the UK, we've kind of broadly moved towards a hub and spoke model for laboratories, where we've got large laboratories that cover, several smaller hospitals, and then you've got the logistics problem of transporting samples from the hospital to the lab, which might not be on site. But in Wales, since the pandemic, we've developed a hot laboratory approach where we do have a large laboratory that does all the heavy culture work and the high volume work. But we've also set up smaller labs at the small hospitals, which the function of those is to house the molecular platforms. So in the pandemic, it was obviously viral PCR for SARS-CoV-2, but it still is. But also we can now do molecular diagnostics for gram-negative pathogens that we've talked about today, but also for other pathogens like C. diff as well.
Yeah. So even in those tiny hot labs, you foresee that this testing for mechanisms of resistance is going to be available? And how
It will
well
be,
do
yeah.
those tests correlate with phenotypic results? Can you have non-expression as an issue? So something tests positive with your genetic testing, it's positive, but actually it's not causing a problem.
Yeah, and I think the answer is yes, but I think we need to wait for kind of large scale data sets to be, I guess, to be confident in the link between genotype and phenotype, and also, and in my mind, you know, if you detect something, that's fine, but if you don't, I mean, what's the negative predictive value? I'm not sure. So I think that's something we'll kind of learn as we go.
Something to see.
Yeah.
I've got another question. If using Xavi and aztreonam, I think, does that mean avibactam and aztreonam and aztreonam after synergy? Sorry, I don't completely understand this sentence. Is SIR after synergy testing? What dose regimen do you use? Can you interpret that question better than I can?
I can't. Is it in the chat?
Yes.
I can't see it at the moment.
Number
but I think
4, number 3 now in the chat.
I can't see that in my chat.
I think it's asking about the dosing regimen with
maximum, maximum dose. The highest dose you can give for the renal function of your patient. Okay,
thank you. And my last question for you before we move to another panelist. All these treatments that you've described, they're kind of incremental advances at best, aren't they? They're new combinations of beta-lactams and beta-lactamase inhibitors, or they're new inhibitors with old beta-lactams. It feels like sort of tinkering around at the edges a bit. What do you think are the prospects for really new treatments or adjunctive treatments like phage therapy or antimicrobial peptides and sort of real advances?
Yeah, I think we've got to keep our minds open to those things. I know phage therapy has definitely been on the agenda in the UK in the last couple of years, and there's been a big drive, which has, I think, come from the UK government to try and support development of bacteriophage therapy. But from my understanding and research in recent months, I think we're still a fair way off to getting phage therapy rolled out and used in the clinical world in the UK. So it's still more research phase and perhaps occasionally named patient use for compassionate use. The other one, I think, which is promising and I'm excited about the future, is vaccination for urinary tract infection. And that's something that has shown quite some promising results from randomized trials in patients with chronic UTI, and giving a vaccine, which was, I think it was sublingual spray, which included inactivated E. coli, Klebsiella, Pseudomonas, and Enterococcus, I think.
There's a clinical trial going on now in Wales of an anti-E. coli vaccine, isn't there?
Another one, okay.
Elderly patients. I can't remember which one it is.
Yeah, yes. So that's quite a promising approach, because certainly in the UK, our burden of bacteremia and invasive infection is E. coli when we think of gram-negatives, and most of those are due to UTI. So that would be amazing if we could prevent some of that.
Prevention being better than cure.
Yeah.
I wondered if I could bring Professor Wassef in, because I noticed from the data on her slides that KPC was one of the 3 commonest carbapenemases in Wales, but in Egypt it wasn't very prevalent at all. And I wondered what you, Ed, and Professor Wassef thought what might be the explanation. Is it just random chance, or is it different selection pressures from different ways of using antibiotics? Why is that not prevalent in Egypt? Any thoughts? Is it?
The pattern.
Yes, Professor Wasser.
Yes, this is the pattern of resistance in all Egypt. Not only this is not random in Shefa Al-Orman hospital or in another hospital. This is the pattern in many of our research in different countries, in different cities, in different hospitals. This is the pattern. The KPC is rare, and the most prevalent is NDM and OXA 48. So to use, if we use the hospitals which use ceftazidime avibactam, although it is very expensive, they use it cautiously in addition to Asirunam, as Dr. Edward mentioned, because KPC almost is rare or is not present maybe in many hospitals.
Okay, interesting to see the different epidemiologies.
Yes.
Professor White, I know that he has to dash off in a second. I just thought, if you have a second before you go, whether you could comment on Candida auris. So we hear a lot of concerns about Candida auris at the moment, and how much of that are you seeing? And is there a specific RDT for like a lateral flow test for Candida auris, or are we using PCR?
There's specific PCR tests for Candida auris. At the moment, I'm not aware of any lateral flow specific for it. In the UK, I can say it seems to be a south-east to the rest of the UK divide, whereas in London, it does seem to be a problem. And I think that probably it sort of reflects the fact that many people are coming into London. There's much more population migration in and out coming from endemic areas, and also transfer of patients from hospitals in endemic areas. So it is around, and I don't think there's any reason for it not to spread from an environmental perspective. So I think once it's in a country, it's only a matter of time before it comes across. So I think there are PCR tests available, but arguably what we would potentially do is do a screen 42 degrees on SAB with a fluconazole disc on there. And if something grows up, send that for ID and sensitivity testing. And that's like a baseline, quite cheap screen for auris. It's not telling you it's auris, it's telling you've got something that grows at 42 degrees. Glabrata will grow at 42 degrees. So will auris, and then you know that it's resistant. You could do that on chromogenic agar, look for the particular color, and then send that off for confirmatory ID.
Yeah, so that would be useful for non-reference labs to screen. Yeah, that sounds like a useful strategy. Thank you. And I'm also told, I don't know what they're using in Egypt. I'm sure Professor Wasef could tell us, but for treating those resistant fungal infections. But I'm aware that in some parts of the world, for example, in South Africa, they're relying very heavily on mycofungin. But in Europe, there's a directive not to use mycofungin unless it's absolutely necessary because of safety issues. I wondered if you had any views on that. Do you think that's a real major concern?
There have been some sort of hepatotoxicity issues with mycofungin.
Yeah, yes.
And so that was from the original clinical trials. So, from an efficacy standpoint, both Nidula and Casper will probably work equally as well. Whether there's a cost difference, I'm not entirely sure. But arguably, you're in that situation with either any of the other of the echinocandins should work to the same efficacy. Where we are moving forward, so slightly diverting my answer, is that there's now resifungin, which is a once weekly IV echinocandin with a really long half-life. And we're also having a brexafungerp, which is another novel antifungal drug, which is not quite an echinocandin, but it's actually an oral equivalent to an echinocandin. So we are advancing the field forward when it comes to those things. Okay,
that's new to me, really useful to know. Thank you very much. I know that you have to dash off to another commitment, so thank you very, very much for joining us. We really, really appreciate it.
No problem, pleasure. I can take any questions that are outstanding via email, and I'll happily reply to them.
Yes, if anybody else has more questions, please do put them in the Q&A while we still have people available to answer them. But yes, if we have any fungal ones, we shall send them across to you. Thank you very much.
It's been a pleasure.
Cheers. Thank you very much. Bye. I was thinking of asking Dr. Meda. It was quite shocking to see the abuse of sinks that you reported in your presentation, and the failure to use the elbow taps, for example. And it always seems like getting people to change their behaviours is the most challenging part of infection control. And do you think that there's a role? How do we change people's behaviours? Do we need to get behavioural experts in, or do we just need to engineer out all options so that people can, the behaviour is sort of made irrelevant because people have to do the right thing, and engineer our way out of it, as you showed in your hierarchy diagram? What do you think is the answer to those sort of difficult to cure behaviours?
Yeah, I mean, it's there's within every infection control intervention, you have behavioral aspects on one end, and you have the engineering aspects on the other. So it's the behavioral aspects obviously need a lot of time, energy, resource. I mean, they both need it, but one of the behavioral aspects needs continuous investment into education and training, because you've got new staff coming in all the time, whether it's a porter or a cleaner or it's a nurse. So you've got to keep on top of that training constantly, and therefore it's never going to be 100%. Your success is never going to be 100%. And it's whether it's hand hygiene or utilizing a sink as it should be, is no matter, we have seen from our own hand hygiene audit, however useful or not useful they are, you can never achieve the standards that you aspire for. So engineering interventions are better to control these outbreaks clearly, but again, they do come with their own problems, such as, can you do it, and how much will it cost to do these things, and what your alternatives are. Will your alternatives work? So it's really about risk assessment and figuring out what actually works within your own hospital setting.
Thank you. I think it's a real huge challenge. I'm sure it's a challenge in every country to get people to do things differently that they're used to doing in a particular way. If you have any other questions for the panel, we're getting near to your last opportunity to ask them, so do put them in the Q&A box very soon, because we'll be closing the meeting in a few minutes. I don't know whether Professor Wassef, did you have anything that you wanted to raise from the Egyptian side? Has anything that was presented in the other speakers' talks struck you as different from practice in Egypt, or it sounded to me as if your lab does more advanced testing than a lot of UK labs actually do. So I'd be interested in your perspective on what we've been talking about.
Yes. Sure, as you said, the last lecture is very challenging to have the safe water. This is very challenging, and we have a lot to do concerning this issue, because it may be a source of infections and a source of outbreaks and source of very important source for transmission of the superbugs, and so we have a lot to do in this issue. But as regards Dr. Edward, the issue we have in Egypt, that the new antibiotics such as ceftazidime avibactam and ceftriaxone tazobactam, they are present in the Egyptian market, but they are very expensive. They are very expensive. We have two issues as regards these antibiotics. Number one, that the cost for treatment a patient, because the patient, as you know, he needs a long course of antibiotic with this, so it would be very costly. This is number one. And the second, we have to know the pattern of the genotypic resistance before giving this antibiotic. So this is an additional cost. So this is the problem in Egypt. So the clinicians in Egypt used to give empiric, and sometimes they have a bacterial culture result with the PDR, not only XDR pathogen, with all the antibiotics that are present in the results are resistant. So sometimes without MIC, without mentioning MIC, because the result was made by disk diffusion. So only it is written or mentioned resistant, sensitive, or intermediate. Sometimes all the antibiotics are resistant. Sometimes even if MIC is present, it is more than 32, more than 32. So the physician is obliged to give any combination, just random trials, any combination, and if it fails, he gives another combination, and so on. Do you see, in your opinion, that in the hospitals that in which there is no ceftazidime avibactam or ceftriaxone avibactam, it will be costly if we introduce these antibiotics in the hospital? I think, or do you think that it will save money instead of giving more and more combinations haphazardly without an evidence-based?
Yeah, well, I think it's the short-term pain for long-term gain in a way, isn't it? Without knowing your kind of health economic situation in Egypt, sorry, I don't really know how your healthcare is sort of funded, but I guess however it's funded, as you've kind of alluded to, if you can get an expensive or relatively expensive antibiotic and deploy it appropriately, where you've got, MIC data or genotypic data to help you guide therapy, surely that must be better than resorting to combination therapies, perhaps more prolonged, protracted treatment with higher risk of clinical failure, and then the consequence being that it's more costly to your hospital and your healthcare system to have these patients with, recurrent infections or whatever it is. So, if you can cure the infection first time with a more expensive agent, then surely in the long term, that's going to have good impacts in terms of that particular patient, but also infection control in your hospital and stewardship and pressure of resistance. So I think, if you can get them and justify them for those reasons, then that would be good.
We have got one last question for you, Ed. You're not getting away lightly today. It says, to Dr. Bevan, in patients who are known to be colonized with CPE on previous rectal screens, would you still target the CPE in your empirical antibiotics for infections, if not septic?
The short answer is no, because it was quite a detailed question, and you said, would you target them for patients that are not septic? I think that's the key. I think with the colonization with these, multi-drug resistant or pan-resistant with carbapenemases, that's obviously a warning flag. But unless that patient is in septic shock, then I would be quite reluctant to jump in and treat. I suppose you've got to think of the particular patient risk factors as well. And I'm conscious that there's a hematology and oncology audience. So if you've got a fragile, frail patient who's profoundly immunosuppressed, that might also tip the balance in terms of whether you decide to cover the colonizing organism. For example, neutropenic fever in the absence of septic shock, that might tip the balance in one of those fragile patients. But if it's just a patient with symptoms of a simple UTI without any systemic compromise at all, you might hedge your bets and try something that, you know, isn't would be resistant in terms of the colonizing organism. You might just do a trial and error approach just to conserve your last line antibiotics.
Yeah, and going back, how far would you count the rectal swab as relevant? Because after a few months, you could argue that they
that's the thing.
will
That's the
become
other
decolonized.
Yeah, that's the other thing. I think the longer it goes back in time, the less likely it is to be clinically relevant. But saying that, if someone was in septic shock and they had the history of colonization from a few years ago, I probably would still want to cover
You
it.
still would.
We would certainly still isolate the patient and barrier nurse them, even if it was a few years back.
Right. Okay. Thanks very much. I guess these are all hypothetical situations, aren't they? Until you have the actual patient with the exact situation, it can be hard to judge what you would do.
Yeah.
Right. Well, I think we have got to the end of the questions for the panel. Thank you all very, very much for answering them so comprehensively and informatively. It's really appreciated. I think we're getting near to closing the meeting now. I'm going to wrap up. I want to reiterate my thanks to our expert speakers, Dr. Bevan, Professor White, Professor Wasef, and Dr. Meda for their time. And thank you, a huge thank you to Professor El-Barawi and Professor Wasef again for their support putting all the arrangements for this meeting together. And I'd also like to especially thank Giles Hanratty from the college's international team, who has worked incredibly hard organising everything so that we could meet today. And thank you to everyone who's attended and asked your questions. I hope you found it useful and have a good afternoon and a good evening, everyone. Bye.
Thank you. Bye.
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 Thank you.
Bye.